स्पेस नहीं ओपन मध्ये नाही पण ओपन झाली ना तर इथे एक आपली विंडो दिसते ना डायरेक्ट हे होतं नाही एक मिनिट अभी हो गया सर पहले क्या होता है डायरेक्टली ओपन होता है वो लोग नहीं देख पा रहे थे ये एक ही विंडो रहने दो माझी विंडो राहू दे मेरे विंडो को स्पॉटलाइट पे जाते लाइट एवरीवन मेरे लिए So good morning. So today we are going to discuss very important topic, that is pediatric COVID-19. So how to diagnose pediatric COVID-19 and how to give treatment and where to refer this kind of patients. So we will see. So SARS-CoV-2 in children can present in two ways. So in adults, SARS-CoV-2 present in only one way, that is pneumonia is there. But in pediatric patients, it present in two ways, that is acute COVID illness, and second is the multi-system inflammatory syndrome in children and multi-system inflammatory syndrome in neonates. So in two ways, this can present in the pediatric age group. So SARS-CoV-2 is a virus name, and what is the disease caused by that? So that is a COVID. So you have to remember this. So SARS-CoV-2 is a virus, and it can present as a COVID infection. So what is acute COVID illness? So majority, that is 90%, more than 90% have the mild course with a quick and complete recovery within a week, but can be followed by complications like COVID pneumonia, like in adults, but incidence is much less. So you have to remember that majority of the patients, more than 90% will have the mild disease. Only 10% will have the severe COVID. So this is the presentation in the pediatric group. Apart from that, what is multi-system inflammatory syndrome in children or multi-system inflammatory syndrome in neonates? So it can occur few weeks to few months after the acute COVID illness, which could have been mild enough to be unnoticed, and can be seen in neonates born to the COVID positive mothers in third trimester or during the delivery. So any mother or pregnant lady having the COVID infection specifically in the last trimester, or any mother diagnosed at the time of pregnancy, these babies have more prone for the MISN. So multi-system inflammatory syndrome in neonates. So you have to remember this. Then in pediatric COVID-19, you can see in first and second wave, most of the patients are asymptomatic or they are having mild symptoms. So 90 to 95% patients were asymptomatic or mild symptomatic were there. Then less than 5% patient was moderate category, and only 1 to 2% patient was in severe category. And in severe category comes that is severe pneumonia or MISC or MISC. Again, in MISC, some patients are having a mild form of the MISC. So that is comes under the moderate category. So you have to remember this. So most of the patient, more than 95% patient will be having the asymptomatic or mild symptoms. Then less than 5% patient will be moderate, and only 1 to 2% patient will have the severe pneumonia or MISC or MISN. So you have to remember this. Then next, you have to decide how to treat this kind of patients. So this is very important. So if severe pneumonia is there, then that patient, that kind of patient, you have to treat at the level of the DCH. So what is DCH? So dedicated COVID hospital. It is situated at the district place. So for Ahmednagar district, Ahmednagar Civil Hospital is there. So you have to treat this patient at civil hospital. And at civil hospital, that is dedicated COVID hospital is there. Then moderate kind of patient, we are going to treat at the PCCH. So what is PCCH? That is Pediatric COVID Care Hospital. That will be located at the RH level, that is rural hospital at Taluka place. So moderate cases, we are going to treat at the PCCH. And what about the asymptomatic or mild cases? These are the 90 to 95% patients are the asymptomatic or mild cases. And these patients we have to treat at the home management, or if home management is not possible, then you can treat at the CCC. What is CCC? That is a COVID care center. So you have to treat that patient at the COVID care center. So this is very important. So you should know, you should be able to categorize the what kind of patient is there, and you should able to decide where to give the treatment for this patient. So mild patient, you have to treat at the CCC. Home management is preferably, but if patient's relatives are not willing or they are not literate enough, then you have to treat that patient at the CCC. If moderate kind of infection is there, then you have to treat that patient at the PCCH, that is Pediatric COVID Care Hospital. And if severe form of the COVID is there, then you have to treat that patient at the DCH, that is Dedicated COVID Hospital at District Center. Clear? Fine. So concept of the fever clinic. So in first and second wave, we have noticed that whatever patients are there, so first and foremost symptom of the COVID is the fever. So any patient coming with the fever, we have make that fever clinic concept. माननीय मुख्यमंत्री साहेबांनी फ्युअर क्लिनिकचा कन्सेप्ट राबवलेला आहे. आणि फ्युअर क्लिनिक मध्ये कोण असणार आहे? तर माझा डॉक्टर. त्याला माझा डॉक्टर हे नाव दिलेलं आहे त्यांनी. माझा डॉक्टर म्हणजे कोण? एक तर तो CHO असू शकतो किंवा मेडिकल ऑफिसर असू शकतो, कोणी पण असू शकतो. तर त्याचं काम काय आहे फ्युअर क्लिनिक मध्ये, की कोणता पण पेशंट आला तर पहिल्यांदा त्याला बघायचंय की फ्युअर कशामुळे आलेला आहे. ज्यावेळेस आपण पॅन्डेमिक सिच्युएशन मध्ये असतो त्यावेळेस काय प्रत्येक पेशंट आलेला आपल्याला काय करायचं असतो? सस्पेक्ट, वी आर गोइंग टू सस्पेक्ट दॅट ही इज अ कोविड. तर रोल ऑफ द फ्युअर क्लिनिक डॉक्टर काय आहे, की कोणता पण पेशंट आला तर इज इट लाईकली टू बी अ कोविड और नॉन कोविड इलनेस अँड इज टेस्टिंग रिक्वायर्ड. आलेला पेशंट जो आहे तो कोविड आहे का नॉन कोविड आहे आणि त्याला टेस्टिंगची गरज आहे का नाही हे पाहायचंय. जर तो कोविड वाटला तर काय करायचं? सगळ्यात महत्वाचं म्हणजे ट्रायच करायचे. ट्रायच काय करणार आपण? परत आपल्याला डिसाईड करायचंय की हा सिव्हिअर आहे, मॉडरेट आहे का माइल्ड फॉर्म आहे, आणि त्याच्यानुसार तुम्हाला डिसाईड करायचं की ह्या कुठं पाठवायचे. माझा डॉक्टरचं काम काय आहे? पेशंट आला फिवर म्हणून, फिवर म्हणून आल्यानंतर त्याला काय करायचंय की फिवर आहे, ह्या कशामुळे? कोविडचा फिवर आहे का नॉन कोविडचा फिवर आहे. त्याला जर सस्पेक्ट असेल की हा कोविडचा फिवर आहे तर त्याला इन्व्हेस्टिगेशन करायचंय, कोविडसाठी इन्व्हेस्टिगेशन करायचं. ते झाल्यानंतर त्याच्या लक्षात आलं की हा माइल्ड फॉर्म आहे, मॉडरेट फॉर्म आहे का सिव्हिअर फॉर्म आहे. त्या 3 मध्ये कॅटेगरायझेशन करायचं आणि त्याच्यानुसार त्याची ट्रीटमेंट प्लॅन ठरवायचा आहे. सिव्हिअर असेल तर आपण कुठे पाठवणार आहेत? DCH ला पाठवणार आहेत. मॉडरेट असेल तर PCCH ला, आणि माइल्ड असेल तर होम ट्रीटमेंट देणार. जर होम ट्रीटमेंट पॉसिबल नसेल तर आपण CCC ला पाठवणार आहोत. बट ऍट द सेम टाइम काय करायचंय? जर होम ट्रीटमेंट तुम्ही देणार असाल तर ऍट द सेम टाइम तुम्हाला काही पेशंटला इन्स्ट्रक्शन द्यायचे आहेत आणि काही रेड फ्लॅग सायन्स पाहायला सांगायचे. तर काय इन्स्ट्रक्शन द्यायचे आहेत? आपण एक चार्ट मेंटेन करायला सांगणार आहोत पेशंटच्या नातेवाईकांना. तो बघणार आहेत आपण कसा चार्ट मेंटेन करायचा आहे, आणि तो चार्ट डेली जे माझा डॉक्टर आहे त्यांच्याशी कम्युनिकेट झाला पाहिजे. तो जो चार्ट आपण मेंटेन करणार आहोत तो बघणार आहेत आपण कोणता चार्ट मेंटेन करायचा. तर आपण एका केसच्या माध्यमातून हे सिनेरिओ बघणार आहे. सो 13 months चाइल्ड विथ फ्युअर सिन्स 2 days. एक तुमच्याकडे 13 महिन्याचं बाळ आलेलं आहे माझ्या डॉक्टरकडे, आणि त्याला 2 दिवसापासून ताप आहे. तर पहिलं त्याच्या डोक्यात काय येणार? कुड इट बी अ कोविड? हा कोविड असू शकतो का? जर कोविड असू शकतो तर त्याचे सायन्स अँड सिम्पटम्स बघायला पाहिजे. तर कोविडचे सायन्स अँड सिम्पटम्स कसे येतात, एनी अदर व्हायरल इन्फेक्शन सारखेच कोविडचे सायन्स अँड सिम्पटम्स दिसतात. सो यू हॅव टू रूल आउट वेदर इट इज अ कोविड ऑर एनी अदर व्हायरल इन्फेक्शन. त्यासाठी काय करायचे तुम्हाला, तर यू हॅव टू आस्क सम क्वेश्चन्स. कोणते क्वेश्चन विचारणार, सो यू हॅव टू आस्क ऑनसेट कसा आहे, ताप आलेला आहे तर तापाचा ऑनसेट कसा आहे, वेदर इट इज अ हाय ग्रेड और अक्यूट ऑनसेट इज देअर और ग्रॅज्युअल ऑनसेट. म्हणजे अचानक ताप आलेला आहे की हळूहळू वाढत गेलेला आहे ताप. सो यू हॅव टू आस्क फॉर द ऑनसेट ऑफ द फिवर. ऑनसेट कशासाठी विचारायचा, की इफ इट इज अ व्हायरल इन्फेक्शन देन अक्यूट ऑनसेट इज देअर इन व्हायरल इन्फेक्शन. इफ इट इज बॅक्टेरियल ऑनसेट देन इट इज अ ग्रॅज्युअल. बॅक्टेरियल इन्फेक्शन असेल तर ग्रॅज्युअली ताप येतो, व्हायरल असेल तर अक्यूटली ताप येतो. सो यू हॅव टू आस्क दिस क्वेश्चन वेदर इट इज अ अक्यूट इन ऑनसेट और इट इज अ ग्रॅज्युअल इन ऑनसेट. तो पहिली गोष्ट तर ही झाली. दुसरं काय विचारायचं तुम्हाला, इंटरफेब्राईल पिरियड. इंटरफेब्राईल पिरियड म्हणजे काय, ताप ज्यावेळेस नसतो त्यावेळेस बाळ कसं असतं, निश्चित पडलेलं असतं, खेळतं, काय म्हणजे ही वेदर इट इज अ प्लेफुल और ही इज अ लिथार्जिक. सो यू हॅव टू आस्क फॉर द इंटरफेब्राईल पिरियड, की ताप नसताना बाळ कसं बिहेव करतं, खेळतं चांगलं का नाही खेळत. हे कशासाठी विचारायचं, इफ इट इज अ व्हायरल इन्फेक्शन then baby will be playful in the interfebrile period. If it is a bacterial infection, then baby will be lethargic. तर व्हायरल आहे का बॅक्टेरियल आहे आपल्याला रूल आउट करायचे, त्यासाठी हे क्वेश्चन विचारणं गरजेचं आहे की व्हॉट अबाउट इंटरफेब्राईल पिरियड, हाऊ बेबी बिहेव्स इन इंटरफेब्राईल पिरियड, वेदर बेबी इज अ प्लेफुल और बेबी इज अ लिथार्जिक. बाळ खेळतंय व्यवस्थित का बाळ सुस्त पडलेलं आहे, हे तुम्हाला विचारायचं. हा दुसरा क्वेश्चन झाला. आणि तिसरं काय विचारायचं तुम्हाला, की एनी असोसिएटेड सिम्पटम्स, काय असोसिएटेड सिम्पटम्स आहेत का. तर कोविडचे काय असोसिएटेड सिम्पटम्स येतं, आपण पाहिलं फर्स्ट अँड सेकंड वेव्ह मध्ये, की मोस्ट ऑफ द पेशंट विल हॅव द हेडेक, मायल्जिया, फटीग, टायर्डनेस, कोरायझा, कफ, सोअर थ्रोट, रॅपिड ब्रिदिंग, डायरिया, वॉमिटिंग आणि ॲब्डॉमिनल पेन. म्हणजे काय असतं, डोकेदुखी असू शकते, अंगदुखी असू शकते, थकवा जाणवू शकतो त्यांना, नाकातून पाणी येऊ शकतं, खोकला येऊ शकतो, घशात खवखव होऊ शकते, त्यांच्या श्वासाची गती वाढू शकते, नंतर लूज मोशन होऊ शकते, तर उलटी होऊ शकते किंवा पोटात दुखू शकतं. तर हे साईन्स अँड सिम्पटम्स आपल्याला प्रामुख्याने दिसतात. तर तुम्हाला हे बघायचे, जर ह्याच्यातले कोणते पण साईन्स अँड सिम्पटम्स असतील तर यू कॅन सस्पेक्ट दॅट अ पेशंट इज हॅव्हिंग अ कोविड. अपार्ट फ्रॉम दॅट यू हॅव टू आस्क फॉर द हिस्ट्री ऑफ क्लोज और हाऊस होल्ड कॉन्टॅक्ट विथ द कोविड. तुम्हाला काय विचारायचंय, की घरात आणखी कुणाला कोविड झालेला आहे, हिस्ट्री विचारणं खूप गरजेचं आहे. ज्यावेळेस तुम्हाला लेबल करायचंय तर घरात किंवा आजूबाजूला कोणाला कोविड झालेला आहे का हे तुम्हाला विचारणं गरजेचं आहे. त्याच्यानंतर काय विचारायचंय, हिस्ट्री ऑफ फिवर इन पास्ट 2 to 3 months. 2-3 महिन्यापूर्वी कुणाला कोविड झाला का, किंवा बाळाला 2-3 महिन्यापूर्वी ताप आलेला होता. हे कशासाठी विचारणार आहेत आपण, की MIS-चा जो आजार आहे तो नंतर प्रेझेंट होऊ शकतो, त्याच्यासाठी आपल्याला हे विचारायचं आहे. त्याच्यानंतर हिस्ट्री ऑफ कोमॉर्बिडिटी. कोमॉर्बिडिटी म्हणजे बाळाला या आजारा व्यतिरिक्त आणखी काही आजार आहेत का, काही कोमॉर्बिडिटीज आहेत का, आपण बघणार आहेत कोमॉर्बिडिटीज काय काय असू शकतात, तर ते एक विचारायचे आपल्याला. त्याच्यानंतर फॅमिली अँड हाऊसिंग डिटेल्स विचारणं खूप गरजेचं आहे. हे कशासाठी विचारणार आहे फॅमिली अँड हाऊसिंग डिटेल्स, सगळ्यात महत्वाचे फॅमिली अँड हाऊसिंग डिटेल्स. कारण आपण जर होम मॅनेजमेंट दिली पेशंटला तर आपल्याला माहिती पाहिजे की त्याच्या घराची परिस्थिती काय, घरात किती रूम्स येतं, घरात किती नातेवाईक आहेत, तर आपण त्याला होम मॅनेजमेंट इझिली देऊ शकतो. सो यू शुड नो फॅमिली अँड हाऊसिंग डिटेल्स. आता एवढं सगळं झालंय, त्याच्यानंतर आपण काय करणार आहोत, व्हॉट अबाउट कोविड टेस्ट. कोविड टेस्ट करायची का नाही करायची हा सगळ्यात महत्वाचा डिसिजन. सो इन पॅन्डेमिक सिच्युएशन इच अँड एव्हरी सस्पेक्टेड पेशंट यू हॅव टू डू द कोविड टेस्टिंग. आता कोविड टेस्टिंग मध्ये आपण कोणती टेस्ट करणार, आपल्याकडे जे अवेलेबल आहे, मोस्ट ऑफ द जागेवर रॅट अवेलेबल आहे. रॅट म्हणजे रॅपिड अँटीजन टेस्ट, किंवा काही जागेवर RT-PCR अवेलेबल आहे. रॅट का करायची, तर रॅटचा रिझल्ट विदिन 15 to 20 minutes यू विल गेट द रिझल्ट. RT-PCRचा रिझल्ट यायला वेळ लागतो. बट यू हॅव टू डू द रॅट फॉर इच अँड एव्हरी पेशंट इफ अवेलेबल. Testing is recommended ideally for all the suspected cases. However, if resources are scarce, testing may be deferred for children with mild symptoms and no comorbidities and with a known positive contact, and that is labeled as a probable COVID. जर तुमच्याकडे टेस्टिंग करायची अवेलेबिलिटी नसेल तर काय करू शकता तुम्ही, की त्या पेशंटला तुम्ही प्रोबेबल कोविड म्हणून लेबल करू शकता. जर सपोज तुम्ही काम करताय रिसोर्स लिमिटेड एरियाज मध्ये काम करताय, तिथं तुमची रॅटची अवेलेबिलिटी नाहीये किंवा RT-PCRची पण अवेलेबिलिटी नाहीये, पण तुम्हाला हिस्ट्री प्रॉपर मिळालेली आहे सगळी, तर तुम्ही त्या पेशंटला यू कॅन लेबल इट ॲज अ प्रोबेबल कोविड. कोणती टेस्ट करायची आपण पाहिलेलं आहे, रॅट करू शकता तुम्ही. रॅट इज रॅपिड अँटीजन टेस्ट and as early as possible after the onset of the symptoms. If negative, the rat negative आली तर then in that case you have to do the RT-PCR, that is reverse transcriptase polymerase chain reaction. त्याच्यानंतर काय करणार आहेत आपण, बाळाला माइल्ड फिवर सिन्स येस्टरडे मॉर्निंग आहे. माझा डॉक्टर काय करणार आहे, त्याला तपासून बघणार आहे की नो काही आणखी नाही का? नो कप, कोल्ड अँड वॉमिटिंग. आपल्या बाळाला काय कप नाहीये, कोल्ड नाही आणि वॉमिटिंग पण नाहीये. फिजिकल एक्झामिनेशन केले, फिजिकल एक्झामिनेशन वर पण बाळ एकदम नॉर्मल आहे. फादर अंडर होम आयसोलेशन सिन्स 5 days फॉर द कोविड. वडिलांना कोविड झालेला आहे, ते होम आयसोलेशन मध्ये आहेत ऑलरेडी. मदर इज असिम्प्टोमॅटिक, नॉट टेस्टेड अँड ब्रेस्ट फिडिंग. मदर काय आहे? असिम्प्टोमॅटिक आहे, टेस्ट केलेलं नाही मदरची, आणि मदर हे 13 महिन्याचं बाळ आहे, त्याला ब्रेस्ट फिडिंग सुरू आहे. आणखी घरामध्ये आणखी कोण कोण फॅमिली मेंबर असतं? एक ओल्डर ब्रदर इज देअर, फादर अँड 65-year-old ग्रँडमदर इन अ 2-room अपार्टमेंट विथ अ कॉमन टॉयलेट. हे विचारणं कशासाठी गरजेचं आहे? जर आपल्याला होम मॅनेजमेंट द्यायची झाली तर आपल्याला माहिती पाहिजे की घराची परिस्थिती काय आहे. आता ह्याचं डायग्नोसिस काय केलं आपण आतापर्यंत, की ही माइट बी हॅव्हिंग प्रोबेबल कोविड और कन्फर्म माइल्ड कोविड. कन्फर्म कधी म्हणणार आपण? ज्यावेळेस त्याचं रॅट किंवा आरटीपीसीआर पॉझिटिव्ह येतंय त्यावेळेस आपण त्याला कन्फर्म म्हणणार. जर आपण रॅट किंवा आरटीपीसीआर केलेलं नाही, आपल्याकडे फक्त हिस्ट्री आहे आणि रिसोर्सेस नाही आहेत आपल्याकडे, देन यू कॅन लेबल इट ॲज अ प्रोबेबल कोविड. माइल्ड कधी म्हणणार हा सगळ्यात महत्वाचा विषय आहे, की माइल्ड कधी म्हणायचं. आपल्याकडे 3 कॅटेगरायझेशन आहे, माइल्ड, मॉडरेट अँड सिव्हिअर. तुम्हाला हे कळणं गरजेचं आहे की माइल्ड कधी म्हणायचं, मॉडरेट कधी म्हणायचं आणि सिव्हिअर कधी म्हणायचं. जर हे आपल्याला कळालं तर आपण त्याच्यानुसार आपण त्याची ट्रीटमेंट देऊ शकतो. तर माइल्ड कधी म्हणायचं सगळ्यात महत्वाचं आहे की नो सायन्स ऑफ LRTI, म्हणजे लोअर रिस्पिरेटरी ट्रॅक्ट इन्फेक्शन नसलं पाहिजे, म्हणजे फक्त अप्पर रिस्पिरेटरी ट्रॅक्ट इन्फेक्शन पाहिजे. म्हणजे काय, लोअर रिस्पिरेटरी ट्रॅक्ट इन्फेक्शन झालं म्हणजे काय, त्याला फास्ट ब्रिदिंग सुरू झाली. सो नो सायन्स ऑफ फास्ट ब्रिदिंग, फास्ट ब्रिदिंग नाही पाहिजे बाळात. सेकंड थिंग, नो सायन्स ऑफ CNS इन्व्हॉल्वमेंट, म्हणजे सेंट्रल नर्वस सिस्टम इन्व्हॉल्वमेंट नाही झाली पाहिजे. म्हणजे बाळ लिथार्जिक नाही पाहिजे, सोमनोलन्स नाही पाहिजे किंवा सिझर्स नाही पाहिजे. म्हणजे बाळ सुस्त नाही पडायला पाहिजे किंवा बाळाने एकदम झटके नाही यायला पाहिजेत बाळाचे, म्हणजे CNS इन्व्हॉल्वमेंट नाही व्हायला पाहिजे. आणि सगळ्यात महत्वाचं म्हणजे नो सायन्स ऑफ डिहायड्रेशन, म्हणजे बाळाच्या शरीरातलं पाणी कमी नाही झालेलं पाहिजे. जर हे 3 गोष्टी असतील तर देन यू कॅन लेबल इट ॲज अ माइल्ड कोविड. कोणकोणत्या 3 गोष्टी? पहिली तर आहे की नो सायन्स ऑफ फास्ट ब्रिदिंग, सेकंड इज नो इन्व्हॉल्वमेंट ऑफ द सेंट्रल नर्वस सिस्टम, अँड थर्ड थिंग इज द नो सायन्स ऑफ डिहायड्रेशन. ह्या 3 गोष्टी असतील तर देन यू कॅन लेबल इट ॲज अ माइल्ड कोविड. आता हे तुम्हाला माहिती असणं गरजेचं आहे की आपण फास्ट ब्रिदिंग कधी म्हणणार. तर हा चार्ट खूप महत्वाचा आहे. फास्ट ब्रिदिंग कधी म्हणणार? बाळाच्या वयानुसार. जर बेबीज एज इज लेस दॅन 2 months अँड respiratory rate is more than 60, then you will call it as a fast breathing or tachypnea. Then baby is 2 to 11 months and if respiratory rate is more than 50, then you will call it as a tachypnea. If baby's age is 1 to 5 years and respiratory rate is more than 40, then you can label it as a tachypnea. And if baby is more than 5 years and respiratory rate is more than 30 per minute, then you will label it as a tachypnea. हा चार्ट खूप महत्वाचा आहे. हा चार्ट सगळ्यांना माहितीच पाहिजे. ज्यावेळेस आपण होम मॅनेजमेंट देणार आहेत त्यावेळेस पण हा नातेवाईकांना आपण चार्ट एक्सप्लेन करणार आहोत. तर हा चार्ट सगळ्यांना एकदम चांगला माहिती पाहिजे. सिंपल आहे. बाळ जर 2 महिन्यापेक्षा कमी वयाचा असेल तर त्याचा श्वासनाची गती 60 पेक्षा कमी पाहिजे. 2 ते 1 वर्षापर्यंत असेल त्याच्या ते श्वासनाची गती 50 पेक्षा कमी पाहिजे. बाळ जर 1 ते 5 वर्षाचा असेल तर त्याची श्वासनाची गती 40 पेक्षा कमी पाहिजे. आणि जर बाळ 5 वर्षाच्या वर असेल तर त्याची श्वासनाची गती ही 30 पेक्षा कमी पाहिजे. तर हा चार्ट सगळ्यांनी लक्षात ठेवायचा आहे. त्याच्यानंतर काय करायचं आपल्याला? आतापर्यंत आपण बघितलं की हा माइल्ड आहे का नाही, पण ऍट द सेम टाइम तुम्हाला काही कोमॉर्बिडिटीज आहेत का नाही हे पाहायचंय. तर कोणकोणत्या कोमॉर्बिडिटीज असू शकतात लहान बाळामध्ये? एक तर कार्डिओव्हास्क्युलर डिसीज इन्क्लुडिंग हायपरटेन्शन. हायपरटेन्शनचं प्रमाण लहान मुलांमध्ये कमी असतं, पण कार्डिओव्हास्क्युलर डिसीज असू शकतात. तर कार्डिओव्हास्क्युलर डिसीज मध्ये कोणते कार्डिओव्हास्क्युलर डिसीज असतात? सायनोटिक हार्ट डिसीज किंवा सायनोटिक हार्ट डिसीज हे असू शकतात. तर ते आहेत का नाही हे तुम्हाला बघायचे. दिस इज द फर्स्ट कोमॉर्बिडिटी. सेकंड, डायबिटीज आहे का? डायबिटीज पण लहान मुलांमध्ये कमी प्रमाणात असतो, पण ज्युएनाइल म्हणजे टाईप 1 डायबिटीज जो आहे तो असू शकतो, तर तो नाही आहे ना हे तुम्हाला कन्फर्म करायचंय. देन इम्युनोकॉम्प्रोमाइज स्टेट्स. इम्युनोकॉम्प्रोमाइज स्टेट्स मध्ये काय पाहिजे तुम्हाला? की बाळाला HIV नाही ना किंवा बाळाला स्टेरॉइड थेरपी काही सुरू नाही ना, म्हणजे बाळाचं इम्युनोकॉम्प्रोमाइज स्टेट्स नाही ना हे तुम्हाला लक्षात घ्यायचे. नंतर क्रॉनिक लंग डिसीज. क्रॉनिक लंग डिसीज मध्ये काय पाहणार आहात तुम्ही? की बाळाला अस्थमाचा वगैरे काही आजार नाहीये ना. दॅट इज व्हेरी कॉमन इन पेडियाट्रिक एज ग्रुप. त्याच्यानंतर क्रॉनिक किडनी डिसीजेस की नेफ्रोटिक सिंड्रोम सारखा आजार आहे का ते तुम्हाला रूल आउट करायचे. नंतर क्रॉनिक लिव्हर डिसीजेस आहेत का? काही सेरेब्रोव्हॅस्क्युलर डिसीजेस आहेत का? सेरेब्रोव्हॅस्क्युलर डिसीजेस मध्ये सेरेब्रल पाल्सी इज व्हेरी कॉमन इन पेडियाट्रिक एज ग्रुप, सो यू हॅव टू रूल आउट दॅट. अँड लास्ट म्हणजे ओबेसिटी. सो ओबेसिटी इज अगेन अ कोमॉर्बिड condition in pediatric age group and also in adult age group. As already you have seen in first and second view that so many obese patients suffered very badly in COVID situation. So these are the comorbidities. So you have to look all these comorbidities, and if these comorbidities are there, suppose comorbidities आहेत, ह्या कशासाठी बघायच्यात आपल्याला comorbidities? We have to decide की पेशंटला कुठे पाठवायचं. जर comorbidities असतील, if no ready access to the health care, then you have to admit that patient to the PCCH. माइल्ड पेशंट आहे पण त्याला कोमॉर्बिडिटीज आहेत, तर आपण कुठं ऍडमिट करणार आहे त्याला? इन स्पाइट ऑफ पेशंट इज माइल्ड बट कोमॉर्बिडिटीज आर देअर, अँड इफ रेडी ऍक्सेस टू द हेल्थ केअर इज नॉट देअर, पेशंट इझिली जाऊ शकत नाही हॉस्पिटलला, देन इन दॅट केस यू हॅव टू ऍडमिट दॅट पेशंट टू द PCCH. कोमॉर्बिडिटी कंडिशन आहेत पेशंटला, बट इफ रेडी ऍक्सेस टू द हेल्थ केअर अँड रिलायबल अटेंडन्स, पेशंटचे नातेवाईक लिटरेट आहेत, हॉस्पिटलला लगेच येऊ शकतात, अशा कंडिशनला तुम्ही त्याला होम मॅनेजमेंट देऊ शकता. इन स्पाइट ऑफ पेशंट इज हॅव्हिंग अ माइल्ड फॉर्म ऑफ डिसीज विथ कोमॉर्बिडिटीज. तर हे माहिती असणं गरजेचं आहे. आपली ट्रीटमेंट त्याच्यावर डिपेंड करणार आहे की पेशंट माइल्ड आहे आणि कोमॉर्बिडिटीज आहेत का नाहीत. जर कोमॉर्बिडिटीज असतील पेशंटला, रेडी ऍक्सेस नाहीये, तर डायरेक्टली यू हॅव टू ऍडमिट दॅट टू द PCCH. कोमॉर्बिडिटीज आहेत, रेडी ऍक्सेस आहे, नातेवाईक लिटरेट आहे, देन यू कॅन गिव्ह द होम मॅनेजमेंट. आणि जर कोमॉर्बिडिटीज नसतील तर डायरेक्ट आपण होम मॅनेजमेंट देणार आहोत पेशंटला. इथपर्यंत क्लिअर आहे? आता सुपरवाइज होम मॅनेजमेंट मध्ये आपण काय करणार आहोत? सगळ्यात महत्वाचं, तर सगळ्यात महत्वाची गोष्ट आहे स्टे होम बाउंड क्वारंटाईन फॉर 14 days. आपल्याला होम क्वारंटाईन करायची 14 दिवसांसाठी करायचे. आता आपण पाहिलेलं आहे की मोस्ट ऑफ द पेशंट्स आर हॅव्हिंग असिम्प्टोमॅटिक ऑर माइल्ड सिम्प्टोमॅटिक, तर त्यांना 2-3 दिवसात बरं वाटायला सुरू होतं. बरं वाटल्यानंतर नातेवाईक लगेच त्यांना बाहेर घेऊन जातात. तर असं केल्याने काय होईल? तो इन्फेक्शन जास्त प्रमाणात वाढत. तर बाळ बाहेर गेलं, बऱ्याच लोकांना त्याचं इन्फेक्शन होऊ शकतं. सो यू हॅव टू टेल टू द रिलेटिव्ह दॅट की बेबी शुड बी क्वारंटाईन फॉर 14 days. 14 दिवसासाठी त्याला क्वारंटाईन आपल्याला ठेवणं गरजेचं आहे. सेकंड थिंग, ग्रँड मदर टू स्टे सेपरेट. आपल्या केसमध्ये काय, ग्रँड मदर आहे, एक ग्रँड मदर इज अ हाय रिस्क पॉप्युलेशन, तर तिला एक सेपरेट रूम मध्ये ठेवायचे. 2 रूमचा अपार्टमेंट आहे, 2 रूम मध्ये, एका रूम मध्ये फादर आहेत, फादर बरोबर बेबी राहू शकतं, आणि एका रूम मध्ये आजीला ठेवायचं. नंतर अदर फॅमिली मेंबर्स टू वेअर द मास्क. बाकीच्या फॅमिली मेंबरने काय करायचं? मास्क वापरायचे आहेत. तर आपण आतापर्यंत काय पाहिलेलं? SMS प्रोटोकॉल पाहिलेला. व्हॉट इज SMS? सो सोशल डिस्टन्सिंग, मास्क आणि सॅनिटायझेशन. सो यू हॅव टू टेल टू द रिलेटिव्ह की फॉलो SMS. सोशल डिस्टन्सिंग फॉलो करा, मास्क वापरा आणि सॅनिटायझेशनचा वापर करा. तर हे आपण इथं फॉलो करणार आहोत. त्याच्यानंतर बाळाला काय करायचंय? फुल नॉर्मल डाएट. जर बाळ तोंडाने घेऊ शकत असेल तर यू हॅव टू गिव्ह फुल नॉर्मल डाएट. आपल्या बाळाचं 13 महिन्याचं आहे तर यू हॅव टू कंटिन्यू द ब्रेस्ट फिडिंग टू दॅट बेबी. मदर निगेटिव्ह आहे, इन स्पाइट ऑफ दॅट यू हॅव टू कंटिन्यू द ब्रेस्ट फिडिंग. जर ब्रेस्ट फिडिंग नाही दिलं तर बाळ कुपोषित होण्याची शक्यता असते. त्याच्यामुळे यू हॅव टू कंटिन्यू विथ द ब्रेस्ट फिडिंग. बट मोस्ट इम्पॉर्टंट थिंग इज यू हॅव टू गिव्ह द एक्स्ट्रा फ्लुइड इंटेक. एक्स्ट्रा फ्लुइड इंटेक कशासाठी द्यायचा आहे? की बाळ बऱ्याचदा पाणी पित नाही. आजारी असताना नॉर्मली बाळ कमी पाणी पितात, आणि आजारी असताना तर ते आणखीन त्याचं प्रमाण कमी होतं. आणि जर बाळाने पाणी पिलं नाही तर ते डिहायड्रेशन मध्ये जाईल. जर डिहायड्रेशन मध्ये झालं तर माइल्ड फॉर्मचा जो डिसीज आहे तो मॉडरेट मध्ये जाईल अननेसेसरली. सो यू हॅव टू मेंटेन द हायड्रेशन ऑफ द बेबी. फॉर मेंटेनिंग हायड्रेशन यू हॅव टू गिव्ह द एक्स्ट्रा फ्लुइड. सो एक्स्ट्रा फ्लुइड यू कॅन गिव्ह प्लेन वॉटर, यू कॅन गिव्ह कोकोनट वॉटर, you can give lemon water, or you can give ORS liquid. So all these is readily available. तुम्ही काही पण देऊ शकता. तुम्ही साधं पाणी देऊ शकता 2-2 तासाला, किंवा नारळ पाणी देऊ शकता, किंवा लिंबू सरबत देऊ शकतात, किंवा ORSचं लिक्विड देऊ शकतात. ह्याच्यामधलं काही पण तुम्ही देऊ शकता जे रेडीली अवेलेबल आहे. त्यातली त्यात नारळ पाणी जर रेडीली अवेलेबल असेल, त्यासाठी कोकोनट वॉटर इज द रिच सोर्स ऑफ मिनरल्स अँड इट विल हेल्प इन मेंटेनिंग द हायड्रेशन ऑफ द बेबी. ते सगळ्यात चांगलं आहे. कोकोनट वॉटर जर देऊ शकत असाल तर ते. जर कोकोनट वॉटर पण नाहीये, नॉर्मल पाणी आहे, नॉर्मल पाणी 2-2 तासाला द्या. किंवा आपल्याकडे सगळ्याकडे ORS रेडीली अवेलेबल आहे. तुम्हाला माहिती आहे ORS कसं बनवायचं? एक जे पाकिट असतं ते 1 लिटर पाण्यात टाकून आपण ते 24 तासाच्या आत वापरायचं आहे. सो यू कॅन यूज ORS ऑल्सो. बट बेसिक थिंग इज यू हॅव टू मेंटेन द हायड्रेशन ऑफ द बेबी. तर हायड्रेशन मेंटेन नाही झालं तर तो अननेसेसरली मॉडरेट मध्ये जाईल आणि आपल्याला तो रेफर करायची वेळ येईल. सो यू हॅव टू मेंटेन द हायड्रेशन ऑफ द बेबी. जर बाळाला घशात खवखव वगैरे असेल आणि मोठं बाळ असेल तर यू कॅन गिव्ह द वॉर्म सलाईन गार्गल्स. वॉर्म सलाईन गार्गल देऊ शकता तुम्ही. आणि यू हॅव टू गिव्ह ओनली सिम्प्टोमॅटिक ट्रीटमेंट, नो अँटीबायोटिक्स, नो इन्व्हेस्टिगेशन. सो माइल्ड ज्यावेळेस डिसीज असेल त्यावेळेस तुम्हाला काही एक इन्व्हेस्टिगेशन करायची गरज नाहीये, किंवा तुम्हाला काही अँटीबायोटिक द्यायची पण गरज नाहीये. फक्त सिम्प्टोमॅटिक ट्रीटमेंट द्यायची. आता सिम्प्टोमॅटिक ट्रीटमेंट मध्ये काय देणार आहेत आपण? ताप आला तर तापेसाठी औषध देणार आहेत. तुम्हाला सगळ्यांना माहिती जे पॅरासिटामॉल आपण देणार आहोत. पॅरासिटामॉलचा 2 डोस किती आहे? 10 ते 15 mg per kg per dose every 4 to 6 hourly you have to give paracetamol. So that is the dose. You should remember this dose. That is very important. 10 ते 15 mg per kg per dose 4 ते 6 तासाला तुम्ही तापेसाठी पॅरासिटामॉल देऊ शकता. सगळीकडे सगळ्या PSC ला RS ला अवेलेबल आहे. 5 ml मध्ये 120 किंवा 125 अवेलेबल असतं. 5 ml मध्ये 250 मेडिसिन अवेलेबल असतं. त्याच्यानुसार त्याचा डोस ठरतो. जर 10 किलोचा असेल तर जर तुमच्याकडे 125 किंवा 120 सिरप असेल तर तुम्हाला 6 ml 4 ते 6 तासाला द्यायचे. तर ते 250/5 असेल तर 3 ml तुम्ही 4 ते 6 तासाला देऊ शकतात. पण तुम्हाला कॉन्सन्ट्रेशन माहिती पाहिजे की तुमच्याकडे कोणतं अवेलेबल आहे मेडिसिन. 120 का 250 अवेलेबल आहे हे माहिती पाहिजे. आणि त्याच्यानुसार आपण पॅरासिटामॉल इज अ व्हेरी ड्रग फॉर द फिवर मॅनेजमेंट. सगळ्यात महत्वाचं हे लक्षात ठेवा, नो अँटीबायोटिक्स अँड नो इन्व्हेस्टिगेशन रिक्वायर्ड इन द माइल्ड केसेस. आता होम मॉनिटरिंग काय करायची आपण बाय द पॅरेंट और अंगणवाडी वर्कर. आपण होम मॅनेजमेंट मध्ये एक तर मॉनिटरिंग करायला सांगणार आहे पॅरेंट्सला. पॅरेंट्स जर पॉसिबल नसेल तर अंगणवाडी वर्कर किंवा आशा वर्करचा आपण मदत घेणार आहोत. आता इथं आपण काय काय हे करणार आहोत, मॉनिटरिंग काय ठेवणार आहोत. आपण सगळ्यात महत्वाच्या 5 गोष्टी मॉनिटरिंग ठेवणार आहोत. So you have to maintain the chart, and in chart you have to maintain the 5 parameters. So you have to maintain the temperature monitoring, then pulse, then SpO2 monitoring, then urine output and rapid breathing. These 5 parameters you have to monitor, and you have to keep the chart of these 5 parameters. So you will see this is the chart. So in this chart you can see, and you have to maintain this chart for 3 times. You have to tell to the relatives you have to maintain this chart 3 times a day. That is in the morning 8 a.m., in the afternoon 2 p.m., and again in the evening 8 p.m. So you have to maintain this chart. So first thing is the temperature. So what is the normal body temperature? So you have to tell to the relatives the normal body temperature is 36.8 plus or minus 0.7. So more than 37.5 is a fever. Or in degree Fahrenheit, 98.6 plus or minus 0.5 degree Fahrenheit. So more than 99.1 is a fever. So you have to tell to the relatives. Otherwise, the relatives will tell, even if it is a 98, they will say that is fever is there. So you have to tell to the relatives that if it is a more than 99.1, then it is a fever. In the evening timing, it can reach up to 99.5. It is a normal because of the diurnal variation. It is a normal. But you have to tell to the relatives that up to 99.1 is a normal body temperature, and in degree centigrade up to 37.5 is a normal body temperature. Apart from that, pulse. So normal pulse rate is 60 to 100. More than 100 is a tachycardia. So you have to tell to the relatives that you have to see for the pulse rate. And pulse oximeters are available. We are going to give to the relatives. We have procured so many pulse oximeters, and we are going to give for the 10 days to the relatives. So you have to give that, and you have to monitor the pulse. To monitor 2 things, that is pulse, that is heart rate, and second is saturation. So if pulse is more than 100, then it is a tachycardia. Then third thing is respiratory rate. So already we have seen the respiratory rate chart. So again, along with this chart, we are going to provide this respiratory rate chart. So less than 2 months, if it is more than 60, then it is a tachypnea. If baby is 2 to 11 months, if it is more than 50, then it is tachypnea. 1 to 5 years, if it is more than 40, then it is tachypnea. If it is more than 5 years, if it is more than 30, then it is a tachypnea. You have to tell to the relatives. And how to take the respiratory rate, that is very important. So you have to open the close of the baby, and you have to see the abdominal movement of the baby for the 1 minute. That is very important. For 1 minute, you have to count the abdominal movements. For how many times abdomen is going up and down. And that is the respiratory rate. Why you have to count the abdominal movement? Because in pediatric age group, respiration is abdominothoracic. For that, you are going to see for the 1 minute. What is the respiratory rate? And according to this chart, you have to measure it. Then apart from that, SpO2. SpO2 should be more than 94%. If it is less than 94%, then it is a alarming sign. So you have to tell to the relatives, measure SpO2, and proper position of the SpO2 probe should be there. Many times after applying the SpO2 probe, it is showing little bit on lesser side. So you have to tell to the relatives, properly apply the SpO2 probe and count for 1 minute. So that will give correct reading. So more than 94% is a normal reading. Then you have to look for the urine output. So baby should pass at least 4 to 6 times urine within 24 hours. At least 4 to 6 times. If he is passing less than that, then it is suggestive of the patient is having a dehydration. So you can see if temperature is more than 102 Fahrenheit or saturation is less than 94% or baby not pass urine for more than 6 hours, then you have to immediately inform to the fever clinic. At the specifically, you have to give the daily reporting should be there to the fever clinic doctor. That is Maza doctor. You have to tell to the relatives the daily reporting should be there. But if alarming signs are there, if temperature is more than 102 Fahrenheit, or if saturation is less than 94%, or if baby is not passing urine for more than 6 hours, then immediately you have to inform to the Maza doctor. And also you have to explain to the red flag signs to the relatives. So what are the red flag signs? So we will see these are the red flag signs. If baby is having persistent fever for more than 3 days, if decreased urine output is there, if lethargy or drowsiness is there, if rapid breathing is there, hypoxia or saturation less than 94%, if rash is there, any kind of rash, urticaria rash or erythematous rash or maculopapular rash is there, if baby is having red eyes or red lips, or baby is having altered sensorium convulsions, then baby turns into the moderate disease. So you have to look for these all red flag signs. So whenever we call it as a mild, that is when a baby is mild, no signs of rapid breathing, no involvement of the CNS, and no signs of dehydration, then it is a mild disease. Here you can see persistent fever for more than 3 days, decreased urine output. Decreased urine output means it is a sign of dehydration. Then lethargy or drowsiness, it is a sign of CNS involvement. Then rapid breathing, it is a sign of LRTI. Then hypoxia, it is a sign of LRTI. Rash or red lips or red eyes, it is a sign of MIC or MIC. Convulsions or altered sensorium, it is also sign of MIC or MIC. If any one of these is there, then patient is converted into the moderate disease. So you have to see for these red flag signs. So in our baby, on day 4 of illness, fever was 100 to 101 Fahrenheit. Child is dull, very lethargic, not eating at all, passing less urine, no breathing difficulty, tachycardia is there. So this patient is converted into mild disease to the moderate disease. Our patient is converted into the mild disease to the moderate disease. So again, you have to inform to the fever clinic. So at this point, fever clinic doctor will decide whether it is a moderate disease or not. And according to that, he will act. So what he will do, he will see the status of the RAT or RT-PCR report. If status of the RAT or RT-PCR is positive, then he will refer this patient to the PCCH along with the family members. So who should accompany the baby in our case? Mother should accompany because mother is a breastfeeding. But if mother is not a breastfeeding, then you can refer along with the father because father is already a COVID positive. But in our patient, mother is a breastfeeding. That's why we are referring along with the mother. You have to maintain the later. So if status of RAT or RT-PCR is negative or not done already, then again you have to keep that patient in the holding area of the rural hospital or PSC, and again you have to do the RAT or RT-PCR. And if a RAT or RT-PCR is positive, then you have to admit that PCCH. If RAT or RT-PCR is negative, then you have to manage this patient as a COVID negative, and you have to manage according to that. Whether baby is having dengue fever, malaria, or rickettsial fever, you have to rule out other causes and you have to treat according to that. So we are in a moderate disease. So in moderate disease, you have to do certain investigations, like you have to do the complete blood count, then CRP, that is C-reactive protein, then SGPT, serum albumin, serum creatinine, serum electrolytes, and X-ray. So in moderate disease also, we are going to do only X-ray test. There is no role of the CT scan. So you have to look for that. And additional investigation as per the comorbidities. You have to do the additional investigations as per comorbidities. And along with that, you have to monitor certain things. So you have to monitor TPR charting. So in mild disease, we are monitoring for 8 hourly. Here, TPR you have to monitor for the 4 hourly. So temperature, pulse, and respiration you have to monitor 4 hourly. Apart from that, you have to monitor BP 8 hourly. Then saturation, SpO2 saturation, you have to monitor 2 hourly if saturation is more than 94%. If saturation is less than 94%, then you have to monitor continuously. Then you have to look for the AVPU scale. So AVPU is alert, whether baby is alert or not. Then whether baby is responding to the verbal stimuli or not. Whether baby is responding to the painful stimuli or baby is unconscious. So this is a very simple AVPU scaling. So this is analog for the GCS scaling. If baby is alert, then it will indicate that baby's Glasgow coma scale is 15 by 15. If it is responding to the only verbal stimuli, it indicates that the baby is having a GCS score of 12 by 15. If it is responding to the painful stimuli, it is indicating that the baby is having a GCS score of 8 by 15. And if it is a baby is unconscious, then it is indicated that GCS is only 3 by 15. So this is a scale for the emergency assessment of the baby. So this is simple scale, that is AVPU scale, alert, response to the verbal stimuli, response to the painful stimuli, or unresponsive. Then again, you have to look for the intake and output charting. And apart from that, additional monitoring as per the comorbidities. So you have to monitor all these things. And according to that, we are going to treat the moderate disease. So again, you have to decide whether saturation is more than 94% or saturation is less than 94%. If saturation is more than 94%, treatment protocol differs. If saturation is less than 94%, treatment protocol differs. So we will see what to do if saturation is more than 94%. So in our patient, if saturation is more than 94%, you have to give the supportive treatment. In supportive treatment, you are going to give, you have to maintain the hydration of the baby. That is very important. Then second thing, you have to maintain the nutrition. Then third thing, you have to give paracetamol for the fever in a dose of 10 to 15 mg per kg per dose, 4 to 6 hourly. If baby is having nasal congestion, then you can put the normal saline nasal drops for nasal block. If baby is having cold, then you can give the cetirizine syrup. So most of the PSCs and RS is having a cetirizine syrup readily available. That is, it is 5 mg per 5 ml is available. So dose of the cetirizine syrup is, if baby is less than 1 year, you have to give 2.5 ml. If baby is 1 to 5 years, then you have to give 5 ml or 5 mg. If baby is more than 5 years, you have to give 10 mg. So 2.5, 5 and 10, you can remember like that. Less than 1 year, 2.5 mg or 2.5 ml. 1 to 5 years, 5 mg or 2.5 mg or 5 ml. And more than 5 years, you can give 10 mg, 5 ml twice a day. Then you can give multivitamin supplements. In multivitamin, we have readily available, zinc is available at our place. So zinc tablet is available and zinc syrup is available. So less than 6 months, you have to give 10 mg of the zinc solution. And more than 6 months, you have to give 20 mg. So you should know what is the dose of the zinc. So less than 6 months, we are going to give 10 mg. So 14 mg tablet is available. 20 mg tablet is available. You have to give for 14 days. If baby is less than 6 months, then you have to give a half tablet. If baby is more than 6 months, then you have to give 1 tablet of 20 mg. If syrup is available, then you have to, according to that, you have to give. Only less than 6 months, you have to give 10 mg. More than 6 months, you have to give 20 mg for 14 days. Apart from that, meter dose inhaler with spacer is to be preferred over nebulization when needed. If baby is required nebulization, then you have to give the meter dose inhaler. And here we are going to give the antibiotics. So which is the preferred antibiotics? So we have to give the ceftriaxone in a dose of 75 to 100 mg per kg per day if evidence of the bacterial infection is there. If you are suspecting bacterial infection, then you have to give the antimicrobials like ceftriaxone 75 to 100 mg per kg per day. And you have to continue the treatment according to the comorbidities. So this is all for the moderate disease with saturation more than 94%. If saturation is less than 94%, then treatment protocol differs. So if whenever saturation is less than 94%, then you have to provide the oxygen supplementation. So how you can provide the oxygen supplementation? So you can give oxygen by nasal prongs You can use non-rebreathing mask. You can use O2 hood for less than 1 year of the age, or you can use the face mask for providing the oxygen. So you have these modalities for the providing oxygen supplementation. So nasal prongs are readily available, and it will also help to maintain the PEEP, that is peak expiratory in pressure. So that will help in maintaining the alveolar open up. So that is the preferred mode of the oxygen supplementation. You can use any one of these, but preferably you have to use the nasal prongs, and that are readily available at all places. Apart from that, you can give awake proning whenever feasible. So you have to give the awake proning position. Then important thing is that you have to give the dexamethasone. This is the only drug proved in COVID situation for moderate and severe disease. So you have to give dexamethasone. So doses is again very important. So you can provide in a dose of 0.15 mg per kg per dose, and you have to give per day. So maximum dose is 6 mg. So 1 ml contains 4 mg. So not more than 1.5 ml you are going to give. So you have to remember this. So dose is 0.15 mg per kg per dose. Single dose is there once a day, and maximum dose is 6 mg, and you have to give this for 5 to 14 days according to the patient's condition. So the dose is very important. If patient is not improving, then you can give remdesivir, but this is not a proven drug. You have to take consultation from the expert who is using remdesivir. Remdesivir dose is again 5 mg per kg on day 1, and after that 2.5 mg per kg per day. So for 5 days you have to give the remdesivir. Then if baby is improving, then you have to decide the discharge plan of the babies from PCCH. So no fever for more than 3 days and baby is stable. 10 days from the onset of the symptoms. So you have to discharge baby if you no fever for more than 3 days or 10 days from the onset of the symptoms, whichever is latter. So you have to decide according to that. Defer vaccination if scheduled it for 4 weeks. So you are not going to give the routine vaccination for at least 4 weeks of the COVID infection. But you have to ensure routine vaccination. Nowadays, so many deliveries are going into hospital. So you have to give BCG vaccination whenever hospitalized delivery is there. So you have to continue the routine vaccination. So you have to remember this. And when to refer to this patient to the IDO or DCH or PICU, in spite of giving oxygen supplementation, if saturation is less than 94%, 90%, if severe pneumonia is there, if patient is not improving, or maybe is having a increased respiratory rate, grunting is there, or signs of retraction are there, or patient is having cyanosis. In that case, you have to refer this patient to the IDU. That is severe pneumonia is there. Then if baby is having evidence of the shock, if baby's blood pressure is on a lower side, then you have to refer this patient to the IDU. If baby is having urine output less than the required, or if baby is not passing urine for more than 6 hours, then it is an indicator of less urine output is there. Then in that case, you have to refer this patient to the IDU. Then if ultrasensorium is there, already we have seen AVPU scale. If P or U is there, then you have to refer this patient to the IDU. If refractory convulsions are there or features of MISC or clinical bleeding is there, then this is a indication for referring to the that is DCH, that is dedicated COVID hospital, and this we will label this as a severe COVID. So if any one of this is there, so you can label it as a severe disease, that is severe COVID. So already we have seen mild disease. When we call that mild disease, no fast breathing, no CNS involvement, no dehydration. Whenever these three are involved, then it is a moderate disease. And when saturation is less than 90%, then in spite of giving oxygen supplementation, then it is a severe disease. When signs of severe pneumonia are there, that is retractions are there, cyanosis is there, grunting is there, then it is a severe disease. If evidence of the shock is there, then it is a severe disease. If no urine output for more than 6 hours, then it is a severe disease. If altered sensorium is there, or refractory convulsions is there, or features of MISC or clinical bleeding is there, then it is a severe COVID infection. And this patient you have to refer to the DCH. While referring, you have to maintain the airway, breathing, circulation of the patient. This is very important. Whenever you are transferring the patient or whenever you are transporting to the higher center, then you have to maintain these basic criteria. So you have to maintain the airway of the patient. you have to maintain the breathing, and you have to maintain the circulation. For maintaining circulation, you have to give the ongoing fluids. Then drugs, you have to give the bolus or sedatives before transferring if needed. And also feeds, you have to stop the feeds. Then you have to check the patency of the IV fluids, and you have to continue the IV fluids, and you have to carry the forms. If you have done the investigations, if you have maintained the charting, you have to send that chart also to along with the patient. So this is very important. Then that patient should be carried with, preferable doctor should be there. If doctor is not available, then at least nurse should be there, or paramedic staff should accompany the patient. So this is very important. Then at severe COVID-19, so this patient will be treated at the PICU or ADU. So this is very important. So you have to refer this patient to the DCH, and at that DCH, all the management will be taken place. So this management will be taken place by the pediatrician or expert in that area. So we will not go in details of this management. So after that, we will see what is MISC. So this is a form of the multi-system inflammatory syndrome in children, and this is seen only in the pediatric age group. This is not seen in the adult. So you have to remember how to diagnose MISC. This is very important. Treatment we are going to give at the DCH levels. So if you are not knowing the treatment, that is okay, but you should know able how to diagnose MISC condition. So we will see how to diagnose MISC. So MISC is a severe post-COVID-19 inflammatory disorder in children. So associated with complications such as cardiac dysfunction, coronary aneurysm, thrombosis, and multi-organ dysfunction. And MISC cases tend to peak 2 to 6 weeks following the peak of COVID-19 cases in the community. So most of the cases we'll see as soon as the pandemic is over. After that, 1 to 3 months, you will get this kind of the cases. So you have to observe these cases. So this is a diagnostic criteria given by the WHO, and this is very simple criteria. So any baby or children and adolescents from 0 to 19 years of the age with fever more than 3 days, with some clinical criteria and some laboratory criteria are there. So you have to look for that. So what are the clinical criteria? So if baby is having a rash or bilateral non-purulent conjunctivitis, or mucocutaneous inflammation, that is red lips or red eyes are there, or hypotension or shock is there, or features of myocardial dysfunction, that is pericarditis, valvulitis, or coronary abnormalities are there, or if baby is having evidence of the coagulopathy, like that is PTT is there, or signs of the GI involvement, if baby is having vomiting, loose motion, or pain in abdomen. If that is there, that is clinical signs and symptoms. Any two of these is there along with laboratory findings. So in laboratory findings, you have to, if CRP is increased, ESR is increased, or procalcitonin levels, if these are increased, then you can label it as a MISC. Along with that, you have to look for any other infection is there. So you have to rule out any other infection, that is if streptococcal infection or staphylococcal infection. So other infection you have to rule out. And apart from that, evidence of the COVID-19, RT-PCR or rat or COVID antibodies. You have to do these COVID antibodies also. If infection is recent onset infection is there, then you will get rat or RT-PCR positivity is there. But if infection is already occurred 2 to 3 months back, then you will not get RT-PCR or rat positivity. So you will get COVID antibodies positivity. And this is a non-infectious condition. So you have to remember this. So MISC is a not infectious condition like COVID infection. So it is a non-infectious condition. So these are the criteria. So you have to remember this. So children and adolescents from 0 to 19 years of the age with fever for more than 3 days, with clinical signs and symptoms, any two of these and laboratory parameters, if these are impaired, then you can label it as a MISC. So again, we will see one index case. So here 4-year boy is there with high fever for 3 days. Mother has noticed urticaria rash. Child is irritable. Tachycardia is there. Conjunctival hyperemia is there. Mild redness of the lips is there. Liver is 1 centimeter and tender. Father had COVID positive 2 months ago. Then what can this be? Can it be a COVID-19, or can it be a COVID-19 related but something else? So it is COVID-19 related but something else. Why it is so? So you can see in our patient also. So mucositis is there. Red lips is there. In some patients, you will get BCG reactivation, then polymorphous rash. You can see here, polymorphous rash is there. So you can get urticarial rash or polymorphous rash or erythematous rash. Any kind of rash you will get. Then conjunctival hyperemia is there. So here, conjunctival hyperemia, that is non-purulent conjunctivitis is very important. So in rest of the conditions, you will get purulent conjunctivitis, but in MISC, you will get the non-purulent conjunctivitis. And some patient, you will get the edema or arthritis. So child and adolescent with fever, with urticarial rash or bilateral non-purulent conjunctivitis, red lips, inflammation in hands or feet, BCG scar reactivation. If marked prostration or irritability is there, if acute GI symptoms or diarrhea or vomiting or abdominal pain is there, tachycardia, tachypnea, oliguria out of proportion to the fever is there, and no other obvious cause for the inflammation like bacterial sepsis, staphylococcus, streptococcal infection is there, and history of COVID-19 or COVID contact with COVID-19 cases in previous 3 months is there, then you are going to diagnose this patient as a MISC. So this is very important. So you have to remember this. Then you have to do the workup of the suspected or MISC or ADU in ADU or PICU. So where you have to treat this patient. So you are going to treat this patient at the DCH, and according to that, you have to do the tier 1 investigations and tier 2 investigations. So tier 1 investigations are again basic investigations are there. There is CBC, CRP, ESR, albumin, SGPT, serum electrolytes, and creatinine. At the same time, you have to rule out other causes of the infection like sepsis, malaria, dengue, scrub typhus, or leptospirosis. If patient is in a shock, then you can do the tier 1 and tier 2 investigation at the same time. Then again, you have to decide what kind of disease is there. Again, MIC is divided into 3 forms. That is, mild form is there, moderate form is there, and severe form is there. So mild form you can treat at the PCCH level. Moderate and severe form you have to treat at the DCH level. So we will not go in details of that. What is the mild form, moderate form, and severe form? But you can remember mild form is having only febrile inflammatory syndrome. So you can treat this patient at the PCCH level. So only PCCH level, that is only you have to give the paracetamol and oral prednisolone. Kawasaki disease-like presentation, you have to give IVIG, that is intravenous immunoglobulin and methylprednisolone. And shock with MODS, you have to give methylprednisolone along with the IVIG if needed. Then we will see management of the COVID positive or suspect mother at the delivery. So appropriate PPE for mother and staff in delivery room. Resuscitation should be done at least 2 meters away from the mother or another room as per the standard NRP guidelines. Test of the neonate for SARS-CoV-2 RT-PCR within 24 hours. So you have to remember this. Any COVID positive mother, if baby is delivered, you have to do the baby's testing within 24 hours. If that test is negative initially and baby is symptomatic afterwards, again you have to do the test. So within 24 hours, you have to do the baby's testing. Mother should, if mother and baby is normal, then you have to give the breastfeeding to the baby. That is very important. While giving breastfeeding, again, mother should wear the mask, do proper hand hygiene and sanitization. That is very important. And you can discharge the baby along with the mother if asymptomatic, and you have to keep the close watch on the baby for at least 2 weeks. Again, if the baby is having a MISN, then it is a rare but present usually in the first 2 weeks. If mother had COVID infection in last trimester or at the time of pregnancy, if mother is having COVID infection, then these kind of babies will present within the 2 weeks. They can present within 1 month, but most of the patient will present within the 2 weeks. So as MIC presentation may be variable and non-specific, you have to look for the whether baby is having fever, vomiting, poor feeding, lethargy, rash, fatigue, breathing difficulty, tachycardia, shock, neurological symptoms are there or not. So you have to rule out whether baby is having sepsis or not. If sepsis is not there, then you can label it as a MIC. So only one thing you have to rule out sepsis. Rule out sepsis and other conditions. Management as per MIC with the age and weight appropriate management. So as per MIC, we are going to treat this patient. So important drug is the IVIG, that is intravenous immunoglobulin and methylprednisolone you can give in this condition. And according to the condition of the baby, you can give CPAP modality for the maintenance of the respiration. If baby is having shock, then you can give the inotropic support. So that is very important. And discharge only for symptomatic for 3 days and active and feeding well. And also in this condition, you have to defer the vaccination for the 4 weeks. So this is all regarding the MISN. So we have seen what is mild form of the COVID, what is moderate form of the COVID, what is severe form of the COVID, what is MISN, what is MISC, and where to treat that patient and how to treat that patient. So this is all regarding the pediatric COVID-19 infection. So this is very important. Thank you so much. Pause.
That was the end of the first speaker. Please join us back at 11:30 for our second talk. We'll be starting off with the next speaker. Next speaker is Dr. Rajesh Gaikwad, sir, professor and of the Community Medicine Department of Dr. Vittal Rao Vikhe Patil Foundation's Medical College and Hospital. Before sir's lecture on epidemiology of COVID-19, we have a short video by sir. I'll just play that.
In December 2019, there was a cluster of pneumonia cases in the city of Wuhan in China. Some of the early cases had reported visiting or working in a seafood and live animal market in Wuhan. Investigations found that the disease was caused by a newly discovered coronavirus. The disease was subsequently named COVID-19. COVID-19 spread within China and to the rest of the world. On 30 January 2020, the World Health Organization declared the outbreak a public health emergency of international concern. In this video, we'll take a quick look at what is currently known about COVID-19. Keep in mind that this is a new disease, and what's known is rapidly evolving and might change in the future. So what is a coronavirus? Coronaviruses are a large group of viruses. They consist of a core of genetic material surrounded by a lipid envelope with protein spikes. This gives it the appearance of a crown. Crown in Latin is called corona, and that's how these viruses get their name. There are different types of coronaviruses that cause illness in animals and humans. In humans, coronaviruses can cause respiratory infections ranging from the common cold to more severe diseases. These include the severe acute respiratory syndrome coronavirus, first identified in China in 2003, the Middle East respiratory syndrome coronavirus that was first identified in Saudi Arabia in 2012, and SARS-CoV-2, the name of the virus that causes COVID-19 that was first reported in December 2019. So, where did this new virus come from? It's known that coronaviruses circulate in a range of animals. Sometimes these viruses can make the jump from animals to humans. This is called a spillover and could be due to a range of factors, such as mutations in the virus or increased contact between humans and animals. For example, MERS-CoV is known to be transmitted from camels and SARS-CoV from civet cats. The animal reservoir of the new coronavirus is not known yet. How does the disease spread? The disease can spread from person to person through droplets, when an infected person releases those droplets through coughing, talking, or sneezing, for example, when close to another person. It can also spread when infected droplets land on objects, and when another person touches them and then touches their eyes, nose, or mouth. What are the symptoms? The incubation period, which is the time taken from exposure to the virus and development of symptoms, is on average 5 to 6 days, but can range from 1 to 14 days. There can be a range of symptoms, from very mild to severe. Some people may not develop symptoms. Common symptoms include fever, fatigue, and respiratory symptoms such as cough, sore throat, and shortness of breath. Some people reported loss of their sense of taste or smell, and some may develop a skin rash. In more severe cases, there could be pneumonia, organ failure, and sometimes death. About 80% of cases recover from the disease without needing special treatment. But there are some people who are at risk of serious illness. They include older people or people with underlying medical problems, such as chronic respiratory disease, obesity, diabetes, high blood pressure, heart disease, or cancer. How can we tell whether someone is infected? The infection is commonly diagnosed by a test called reverse transcriptase polymerase chain reaction, generally known as PCR. This test identifies the virus based on its genetic fingerprint. There's also a blood test that can check for antibodies against the virus, which may show that someone was infected in the past. How is it treated? The treatment for COVID-19 is mainly supportive care. Medicines against the virus are currently under investigation. How do we prevent transmission of the virus? There are a number of effective ways to prevent the spread of the disease. These include covering your mouth and nose when coughing or sneezing with a flexed elbow or tissue, and throwing the tissue in a closed bin immediately after use. Wash hands regularly with soap and water or an alcohol-based hand rub, maintaining at least 1 meter distance from people, and the appropriate use of masks and personal protective equipment, especially in health settings. It's important to stay home if you're feeling unwell and to call a hotline or your medical professional. But if you have a fever, cough, or difficulty breathing, seek medical care early and share your travel history or contact with someone unwell with your healthcare provider. In some areas, governments have implemented specific physical and social distancing measures to prevent the spread of the outbreak. It's important to follow their advice. Vaccines to prevent COVID-19 are currently under development, and scientists around the world are working hard to make this happen. That's a quick look at this emerging infectious disease. We're still learning about this virus every day, and what's known may change. So please, check the website below for the most up-to-date information.
So this is what the picture is of corona. My first book in India is published, Corona Prevention and Control. In brief, we'll discuss about the epidemiology of corona because this disease is new and the epidemiology is also new. We are knowing very few things about it. What's it? It is a large family of viruses known to cause illness. It is a RNA type of virus. We know it since 1950 because it is like common cold, but this is a severe form. We know in 2002 and 3 SARS, then MERS, and now this is COVID-19. Why the name is COVID? Because it looks like corona, crown-like appearance. The Rajacha Mukuta circle. It is beautiful. So the name COVID. But the virus is not beautiful. Yeah, it causes a very dreaded disease. And you might be knowing that the deaths are more ever since the birth of the earth. No disease had killed so much figure mankind till today. So you know the seriousness of the disease. SARS is severe acute respiratory syndrome. This is also SARS, but this is new, NCOV. SARS, N means novel coronavirus. Middle East, though the death rate is near about 35 to 40%, but the attack rate, prevalence rate was very less. Whereas you will find coronavirus, the prevalence was high, though the death rate is less, but ultimate death figure was very high. You might be knowing 4 to 5%. In India, it was 1.5 to 2%. But the figure in crores, so the deaths in lakhs. what we had notified is 80% less than the notifiable figure. So you can imagine how much the cases they are there and how many deaths had occurred. This is started in Wuhan city, Mumbai. It is a China made, so it won't last also for many years, I think. And that's what Madam Soumya, she is the first representative from India in WHO. She is Deputy Director of Epidemic. She is a daughter of great scientist Swaminathan. And you might be knowing, no man or woman had ever represented WHO. She is the first lady preventive medicine specialist and pediatrician working as Director General in WHO. Her assumption, why I'm telling this, because her contribution in this field is extraordinary. She told that we have to live with the COVID up to 5 to 7 years. So this disease will not vanish within months or years. One thing, though the prevalence had gone down, there can be again third or fourth wave. But the severity might be less if you take the vaccination. No doubt after vaccination also there can be a disease, but death will not be there. It is a emerging respiratory infectious disease and it is more what we can say infectious than influenza. We had seen there were pandemic of influenza, even plague, but this is a severe form of pandemic. In 2002, there were cases in India also, SARS-CoV, COVID. 2009, H1N1 influenza. You might be knowing that when I was deputy director, we had taken trainings of MOs, even staff nurses on a large scale of this influenza viral epidemic. Then the Middle East respiratory syndrome, MERS, and then novel, I told you, coronavirus. It had affected 118. It is a figure of 2019. Actually, now it is 188. And only 10 countries where the prevalence is less than 10 figures, but the countries half of the Nagar district. So is the prevalence or cases are less. And otherwise, even US, almost all, India is second in the world. They are affected by the COVID vaccine. It was declared as a global public health emergency on 12th January, and WHO also came to know this is a serious disease. Till that period, 1 month, nobody was knowing that what type of pneumonia it is. Where do coronavirus come from? Mainly it came from seafood market at Wuhan, because Chinese eat anything on the earth. Several known coronaviruses are circulating in animals till date also that have not yet infected. When they infect humans, it is sort of a disease like anthrax or rabies, because it had came from animals to human being. Now it is spreading human to human. We'll see how it spreads. A spillover event is when virus that is circulating in animal species is found to have been transmitted to humans, because it is said that they eat these animals because the main source is from the slaughterhouse of the Wuhan, and then it came to the humans, and first case was notified of pneumonia coronavirus in Wuhan, China. Corona itself is teaming us the precautions. So Corona had taught many things. It is said that it had cleaned the world, even the rivers. I know about, I had seen one video that with 35,000 or more than that crores, Ganga was not clean, but by single pandemic within 1 year, the Corona had done job of more than 1 lakh crore. So that is also a good point regarding the disease. Clean your hands. Why? Because the disease is transmitted not only by droplet, but also by fomites. If you touch any surface where the patient had, talk loudly, send some droplets, you can have a disease without coming in contact with the patient. So that we say it as a indirect. Transmission is by two methods in preventive. Direct by droplet or droplet nuclei. These are not nuclear like tuberculosis. These are big droplets and containing the viruses. So if the person to person contact less than 6 feet comes, it is said that the another person who is healthy can contract the disease. Off from gathering till date, today also, we should avoid the gathering malls, or we should not go in a very, what do you say, the gatherings. And if your immune apparatus is compressed, particularly in HIV or the comorbid conditions like diabetes, hypertension, then they will have a disease very fast, very early, and the severity will be more. Offer hand wash to poor people. No to handshake. जुन्या काळी जे रामराम नमस्कार दुरून करायचे, that is best method. Now we have to follow it, because we don't know whether the viruses they are there on the hand surfaces. It may act like fomites, so there should not be handshaking. Avoid rumors that it kills. No. Corona kills only 5%, and delay means corruption. Like in economic language, if you come late, then that is the treatment. If the patient comes within 12 hours, yes, 100% he will be cured. And 81% near about are mild cases. 15% are moderate. They may come in mild if treated in time, or they may go in severe if not treated in time. So early diagnosis and early treatment is very important in COVID to save the lives. Increase risk in following. I don't know whether you can read it or not, but I will narrate it in a few words. Age 70 years. No, it can be above 60 years with comorbid conditions like cancers, HIV, tuberculosis, even diabetes, hypertension, heart diseases, cancers. And patient above 50 years age, they may contract the disease and have severe consequences. That is the meaning. Comorbid conditions. You might have observed in second wave also, patient died above 60, one thing. Secondly, having comorbid conditions. And youngsters, they are escaped till date. We don't know about the future, but it is said that if the person is immunocompressant, then the likelihood of the severity of a disease is more. Problems, for example, sickle cell disease or lung diseases, because this is mainly a pulmonary disease. It can affect right from hair to toe, all organs, but mainly lung disease. So those who are having asthma, bronchitis, bronchiolitis, the severity of COVID will be more. Or steroid tablets, those who are on steroid, prednisolone, corticosteroids, or chemotherapy, cancer patients. Being seriously overweight, obesity is also a disease. So all these conditions, they increase the risk of the COVID-19. And it is observed, studied that the death rate is high when the old age persons having comorbid conditions. Risk assessment, 20% are reported to be severe, and out of this 5% die. So death rate is 2 to 5. But in India, it is observed that it is 2%, near about 2.5%. But in lakhs, it will be in crores, it will be in lakhs death rate. So by percentage, we think that it is 2%, but it is more than 2 lakhs. So we might have observed that Maharashtra was highest running highest in prevalence as well as death. Nextly, now Kerala is highest. Second is Maharashtra. Till today, even I think 41 patients were admitted yesterday. They were there in the ward of our COVID center, designated center. So the seriousness is still there. One should use mask. Mask is like vaccine. And if you have taken vaccine, doesn't mean that it is prevented, because new strains are coming. You might have seen those who had received 2 doses also had got COVID, but the severity was less. These patients had not died. So Disease can be there. Mask is the safe vaccine. We have to use it for 5 to 7 years. That's what Dr. Swaminathan used to say. So one should be very serious coming 5 to 7 years also, not 5 to 7 months. Overall fatality, I told you, 2.3 to 4%. In US, it was more, 4%. Though US is a small country compared to India, we are highest in the world as far as figure is concerned, prevalence and death. SARS 15%, MERS is 37%. Death rate is high, but prevalence was very less. So we couldn't feel or we couldn't notice also that there were pandemic in 2007. Death rate was very less. Why people had noticed COVID? Because people were killed in lakhs and there were sudden in first wave peak. I think in 2019, from February it started and there was peak in April within 2 months. In second peak, prevalence was less, but death rate was high. And it is said that the third wave is coming in October and November. That's what the projection from other countries, Canada, US had noticed it. We don't know. I think the severity will be less, but there will be cases. And it is said that the pediatric immunization is must, as sir was saying. Why? Because now the affection below 18, the chances are more because they don't have herd immunity. Amongst you, 40% might have succumbed to disease, though not manifested the symptoms. So asymptomatic cases of COVID are more dangerous because they are harboring the viruses but not manifesting disease. It is like HIV, AIDS, window period. The viruses, they are peeping through the window but not manifesting the disease. It is same like in corona, where you will find that in 40% asymptomatic patients or youngsters, they are not coming for treatment, but they are spreading the infection in the community. So this is what the dangerous group is there as far as epidemiologists is concerned. Human coronavirus, up till now, we know 7 strains. There might be more strains also, but we know human COVID 43, SARS COVID. You can take down also these figures because this is very important. MERS COVID and novel coronavirus. That is the 2019 strain. And the vaccine is of this strain. Vaccine you might have taken almost all, but don't think that you are safe after taking 2 doses. That's what I want to stress. You have to use all this procedure. PSM, preventive social, physical distancing, sanitizer, yes, and mask. Viral causes of common cold. It looks like common cold, but it is uncommon disease. Influenza virus, adenovirus, coronavirus, they are of same family. Symptoms, you might have noticed fever, cough with shortness of breath. But one of my friend in April, he was having just loose motions. I said that let the RT-PCR done because I had read that diarrhea can be an unusual symptom that time. And you might be knowing that without fever, cough, there can be simple loose motions and it may turn into COVID positive. RT-PCR was positive and the treatment he got within 12 hours. So don't think that it is must that fever should be there or cough should be there. Simple diarrhea. Then ingousia means you don't have a taste of smell. That may be a manifestation of COVID or body ache, headache, upper respiratory tract infection, simple common cold. Every common cold should be diagnosed for COVID. Like every fever, we used to say, every fever should be supposed as malaria. Take a slide. Like that, every sore throat should be supposed as a COVID. Don't neglect it. It may be common cold, but 90% it can be COVID because the viruses, they are circulating there. Symptoms may appear as early as 2 days before. as I said, asymptomatic patient. Then the frank case after 2 days. And 2 to 5 days, peak. And after 5 to 7 days, CT scan will be positive. And it will last up to 14. You know better, most of the staff nurses, they are working in hospital, that after 7 days, if BP score is more, you may have to put the patient on ventilator, oxygen is needed. And moderate cases can come to mild, or otherwise they will go in a severe form. So this is very important. Then I told you, gastrointestinal symptoms, diarrhea, nausea, vomiting. Don't think that it is gastritis. This is not a period of gastroenteritis. Seen in 20% of the cases, symptoms of 2019 COVID, N COVID, may appear as early as 2 days. So we say that 14 days means it is a quarantine period. After that, patient is free from the disease, but he will have some symptoms up to 4 months. You might have noticed that the patient, particularly diabetic, their sugar level goes up above 500, though it was controlled before the disease 140, 160, and it will take time to subside. It is because of the COVID and the treatment, corticosteroid. I told you, thorough hand washing, the more than 80% after touching the infected surfaces, like ticket counter. These are examples, door handles. If you touch, so it is not necessary that droplet infection will spread the disease. That is direct transmission. But fomites also can, I told you, transmit the disease. It is indirect transmission. Touching the face, eyes, nose without washing the hands. Airborne direct infection. Airborne infection like TB is unknown till date, but it is said that in a room, if the open case of COVID is there in a family, this virus can transmit airborne in the room. So the patient should be isolated in the family also if he turns out to be positive or quarantine. When a nearby person sneezes or coughs, so the transmission is mainly by direct, that is droplet or droplet nuclei. Second is indirect by fomites, and third by airborne in a room. In an open space environment, the viruses, they don't live for longer time. Case definition. What do you mean by case? A patient with acute respiratory illness, history of travel from abroad or from other district, residence in a country, area or territory reporting local transmission during the 14 days prior to symptom. Why this 14 days? That is the incubation period. 2 to 14 days is the incubation period of COVID. On an average, incubation period is 5 to 7 days. So we had quarantine. You might be knowing in airport also, the people for 14 days. Otherwise, if you allow them to go in that country, they will spread the infection. A patient with any acute respiratory illness, with a contact with confirmed case of COVID in the last 14 days, we will say or designate it as a case. Patient with severe acute respiratory infection with no other etiology that fully explains the clinical presentation. And a case for whom testing for COVID is inconclusive. A person with laboratory confirmation, irrespective, I told you, any signs, no fever, no cough, but RT-PCR or rapid test is positive, start treatment. That is the meaning. A contact is a person that is involved in above any following: direct care without proper personal protective equipment. You might be also using, isn't it, PPE, personal protection kits in the wards. It should be used. Staying in the same close environment, workplace, classroom, household or gatherings. Traveling together in close proximity, 1 meter or 6 feet. It is observed that the virus cannot go above 6 feet, 10 feet. But if person comes in contact with 1 meter with the infected person, then he may have a disease. Traveling together in close proximity, less than 1 meter, with a symptomatic case who later tested positive for COVID-19. Key consideration. Surveillance period is for 28 days. It is double the quarantine, 14 into 2. 14 days quarantine and 14 days for observation. A high risk contacts to be tracked, quarantined and lab tested. Low risk contact, lab test only when the person under surveillance develops symptoms. If he develops symptoms, then yes, the patient should be shifted to the ward. If he is all right with your presumptive treatment and in house only, not necessary to admit. 80% are you can quarantine at home, 15% should be admitted, and only 5% will require NICU, ICU, oxygen. What samples to be collected? Throat swabs, nasal swabs. Other bronchoalveolar, tracheal, sputum. It is said that the sputum, yes, viruses, they are there in the sputum. Even fecal-oral, feces contain the virus. Blood, stool and urine culture had shown COVID viruses. Collection, within 3 days of symptom onset, not later than 7 days, because after 7 days you won't find the viruses. Preferably prior to initiation of antibacterial. We give antibacterial because patient go in septic shock. With antiviral, we have to give antibiotics also. No validated serological tests, only PCR tests. RT-PCR is a PCR, polymerase chain reaction test. Infection prevention and control, you may not know, but just I will show a few slides. How this disease is transmitted from the patients, neighbor, even the ward boys, staff nurses, they should take care. Protecting yourself, protect your patients, protecting your family, community and environment. General advice, close contact with people suffering from acute respiratory infections. It may be common cold, asthma, bronchitis or bronchiolitis, anything. Frequent hand hygiene, especially after direct contact with ill people. Particularly, this is important for the staff nurses or their environment. They have to clean the hands always. And people with symptoms of acute respiratory infection should practice. Respiratory etiquette, wear a medical mask. Mask is like a good vaccine. So if you are taken 2 doses, doesn't mean that you are protected or prevented. There can be disease, though the severity will be less. Mask is must up to near about coming 5 to 7 years. That's what I told you, Dr. Madam Swaminathan Soumya told. She is the representative, first lady from India, representative World Health Organization. The hand hygiene, I had repeated it, you know it better. Hand hygiene, use appropriate product. Alcohol-based hand washing is important. So simple hand washing by water is not important, but alcohol mix, sanitizers should be used. Soap, running water, single-use towel, and you should clean hands for 20 seconds as if you are going in operation theater. Surgeon cleans hand. It is not just 1 second job. So cleaning hand is very important. Why? Because I told you, the fomites is the way of a transmission of a disease. Respiratory hygiene, turn head away, cover the nose and mouth with tissue paper, cuff sneeze into your sleeve if you don't have a mask. Don't spit here and there. PPE, face mask, N5 mask, face shield, goggle, you might be using being staff nurse, gown, apron, gloves, head cover. Home care of patients, I had told you, home care of the patient with the mild are most 82%. Use of masks, individuals with suspected infection, relatives, along with hand hygiene, keep distance at least 1 meter, because it is observed by the scientists that the coronavirus, they won't go above 6 feet, 1 meter. Improve airflow in living space. AC should not be used, but fan should be there to flow, to have airflow. mask management. Use of mask, individual without respiratory symptoms, individuals with respiratory symptoms. I told you, this is same. Hand hygiene, gown, mask, goggles, and gloves should be used. Hand hygiene, coughing and sneezing hygiene. That is, you should not throw this anywhere. Practice food safety. Avoid spitting in public places. Seeking care. If you are going to moderate or severe, then go to the hospital. Avoid touching your eyes, nose, and mouth. Avoid close contact. And namaste instead of handshaking, because our hands can be act as a fomites. Management, you may not know this. With these few words, I'll stop here. Any questions? तुमचे काही प्रश्न असेल तर मराठीतून विचारू शकता. इपिडेमॉलॉजी ऑफ कोविड. आपण पाहिलं की 3 गोष्टी महत्वाच्या आहेत. PSM. P म्हणजे डिस्टन्स. S म्हणजे सॅनिटायझर. EM म्हणजे मास्क आणि स्प्रेड. नुसता डायरेक्ट नाही तर इनडायरेक्ट कशामधून? फोमाइट्स. तुम्ही एखाद्या सरफेसला टच केलं तिथे पेशंट सिंकलेला असला, तुम्हाला होऊ शकते. असं काही नाही तुम्ही पेशंटच्या जवळ असावं. आणि तिसरा भाग की एअरबॉर्न मात्र असं हवेतून नाही तर रूम मध्ये. इन एअर, इट इज प्रूव्ड. ते जर 10 फुटाच्या आत असेल पेशंट आणि तुम्ही सगळे घरातली मंडळी एकत्र राहत असाल तर होऊ शकतो. आणि लास्ट बट नॉट लिस्ट, मी तुम्हाला सांगितलं व्हॅक्सिन तर घ्यायलाच पाहिजे, परंतु व्हॅक्सिन घेतलं म्हणजे मी सेफ आहे या भ्रमात राहू नये. 1, गर्दी टाळावी अजून 5-7 वर्ष. 2, आणि मास्क हा नाकावर असला पाहिजे, तोंडावर गळ्यात नाही, नाकावर असला पाहिजे. 1, आणि तिसरी गोष्ट म्हणजे तुम्ही स्प्रेड करणार नाहीत आणि 98% दुसऱ्याने मास्क वापरला तर तुम्हाला त्याच्यापासून होणार नाही. विथ दिस फ्यू वर्ड्स आय विल स्टॉप हिअर. थँक यू.
Thank you, sir. Shortly, we'll be moving on to our next speaker. For our next speaker, we have Dr. Abhijit Divte, sir. Sir is professor and head of the Department of Physiotherapy in Cardiovascular and Respiratory Sciences, including intensive care. Sir is actively working in the field of physiotherapy as a clinician, academician, researcher, as well as an administrator. Sir has vast experience nearly for 15 years in various domains of physiotherapy, education, and has an association with many reputed universities in India as a member of Board of Studies. Sir has been appointed as chairman of various inspections and assessments of various institutes and vice chancellor nominee for staff selection committees by MUHS Nashik. Sir has published more than 40 research papers in national as well as international journals and has written books related to the subject. The recent one being the recommendations for physiotherapy management in COVID-19 in acute care Indian setup. Also, an editorial member of various journals. Sir is a recipient of the Significant Contribution Award in Physiotherapy from the Indian Association of Physiotherapists in its 52nd annual national conference held at Indore in 2014. Sir has been instrumental in the Institute's NAC accreditation process, which has accredited as the first private physiotherapy college in Maharashtra under MUHS. He has recently been awarded a doctorate degree in physiotherapy and is now a recognized PhD guide for doctorate students at the Health University. A member of various national and international academic bodies such as the American Thoracic Society, New York, USA, European Respiratory Society, Switzerland, Asian Pacific Society of Respirology, Japan. Sir is also director at the District Disability Rehabilitation Center of Ahmednagar, jointly run by the Dr. V.V. Patil Foundation's District Social Welfare Department in a project under the Gramin Punarvas Yojana of Ministry of Social Justice and Empowerment, Government of India. I would like to welcome Sir for this session. Sir will be talking on role of physiotherapy in COVID care. Over to you, sir.
Good afternoon, everyone. Thank you for that warm invitation and for inviting me for the session of the session on COVID-19. I thank Medical College and mainly in general and Department of Microbiology in particular for giving me this topic for presentation. We all have been dealing with COVID since last 1.5 years, and I do understand that everybody fully or partially is aware of what COVID exactly is. I understand these topics have been already covered by other speakers like microbiology of COVID and some like immune responses in COVID and post-COVID management and its complications, lab diagnosis and treatment protocols of COVID-19, COVID-19 vaccination, and today by Dr. Misal regarding COVID-19 management under 18 years. And recently our honored speaker, Dr. Gaikwad sir, has spoken about epidemiology of COVID-19. Today I will be mainly speaking as a physiotherapist. I will be speaking about the role of physiotherapy in management of COVID. What may be known to many of them, but then I would really like to know, as managing COVID, it is a multidisciplinary team approach. It is not a one man's job, and the team involved, like physicians, microbiologists, pulmonologists, radiologists, ICU specialists, we as physiotherapists, the nursing experts, and various interdepartmental and interinstitutional, interprofessional residents and interns, and all allied healthcare team. It is not a one man's job. Everybody is involved in running the task successfully. As physiotherapy, the main role of physiotherapy was early established, starting with musculoskeletal issues. And then we went to neurology, and then for ICU care, chest physiotherapy. Main evidences, if you see if you ask anybody about physiotherapy, was mainly known for musculoskeletal and neurocancer. But then it is now going into pediatrics, then it's going to sports. Then we have something physiotherapy for obstetric and gynec. And then we go for oncology rehab, we have cardiac rehab, we have pulmonary rehab. So many things are coming up. And chest physiotherapy and pulmonary rehab is the one component which we would be discussing today. And what's known or main aspects are, what is everybody, if anybody can tell, is regarding early ambulations and improving mobility. Then the main role or mainstay was known for reducing hospital stays by giving early discharges, improving pulmonary functions, avoiding post-op complications, and overall, by doing all this, achieving all these targets, we help in overall reducing the morbidity and mortality. So what was missed here? So we just know that it is a part of component of the treatment team. So what we know, it has to be an individualized treatment approach. We cannot generalize, as we say, if a drug protocol, as we have discussed here, we have a protocol for mild, moderate, severe. So above this score, above this age, give this dose. So it cannot be here in physiotherapy. We have to have an individualized approach for every patient. You have to understand what is the patient thoroughly by having a thorough examination in and out. You have to have a detailed examination, detailed assessment of his functions, and then you have to have an individualized treatment approach. It is, as I said, it cannot be prescribed or it cannot be supervised virtually. You have to have a treatment contact session. A therapist has to be by the patient, next to the patient, to see that the treatment protocol is delivered and is supervised effectively. By giving this, it is not merely that he belongs to such category or such group and you just give him. We have to have a clear understanding and clear idea about what are his comorbidities and what are his pharmacological considerations. Because whatever activity you would be giving, exercise you would be giving, that would have an impact, or we will have some limitation. That both the things would be there. So whether the patient before coming to COVID or being diagnosed with COVID had some earlier issues with cardiac functions, pulmonary functions, or is he even compromised with some oncology issues or any other issue, we have to have that consideration. And we have to have knowledge is what pharmacy he's on, what medications he's on, so that our parameters, when we are monitoring the patient for his heart rate or pulmonary functions, we have to have an idea what the patient's response would be to that exercise protocol. And as I told, we cannot have it with all due respect to everybody. It is not that, prescribe a medicine or IV is given or an injection is given and you finish it. And then the staff and it is observed. It is a long duration contact session. We have to start with all the session. It is supervised and time consuming session. We have to be there bedside, supervise all I will be discussing various exercising modalities. We start from basics of breathing exercises, let it be chest expansion, thoracic expansion, or using other modalities. It is a time consuming session. So that is, and it is fully based on understanding and cooperation. It is not that you just give it and you're finished. And then he has to understand what we are giving. He has to comply to that. He has to cooperate, because it is also main part is patient's perception about that physiotherapy, what we are trying to give or what is our role and what he is going to benefit from that. Because see, when he is coming, what the perception is that I have to take a rest. I am coming here for, rest, for management. So why is somebody asking me to get out of bed and asking me to do some exercises when I'm not feeling well? I'm not at all good. I'm so weak. I'm needing oxygen. And why this person is coming and asking me to do such kind of exercises in this hard situation? So it is not so. So it is totally, we have to convince them what is the effect, what is the impact of that. And accordingly, once he understands, then his cooperation is expected in doing this effectively. And strict compliance and regular follow-ups are very essential. It is not that on day one, I go and teach him and then he would do it and my role is over. No. We have to set some targets. Yes, in this 7 days, he has to do so, or in this next coming 14 days. So we have to set some targets, some goals, and regular follow-ups are very essential. So challenges, everybody has faced challenges. You have been frontline workers, and I have a lot of honor for you all, that you all have done a fantastic job. But then there are multiple challenges, as you as frontline workers have faced. So there are challenges at different levels, at tertiary care hospital. What are challenges? So challenges would differ from, we know when we are dealing with patients in routine ICUs, MICUs, NICUs, or surgical ICUs, the protocol is totally different. But this is a pandemic protocol. You have all restrictions everywhere lying down. From entering the door itself, then the health status, you have to look at I've written physical, functional, and mental. Physical status of patient, what is his functional status, exactly what he can do right now, plus his mental status, what is his perception. As I told earlier also, the diagnosis itself that you are having COVID itself takes a mental toll. And it is a very big thing for anybody to know that I have a COVID. And that scary situation itself creates a lot of chaos And that chaos will hamper his mental performance plus as well as physical performance. Into two means I want to say, even of a therapist who is going to go inside, he also has to have that fitness, level of fitness. He has to have that functional mobility, and he has to have that mental strength to go inside and treat those patients. As I said, it is a contact session. You have to go bed to bed, patient to patient, and deliver your exercise session and make them understand what is the role and what is the importance of doing. And that comorbidity consideration, we have to look into it, whether he has some other issues, looking into those issues and his other functional, whether he has undergone some surgeries, he has some cardiac issues, renal issues, or any other issues, looking into it, plus COVID, we have to see it and we have to accordingly modify our treatment protocol. So again, mobility restrictions, physiotherapy, everybody knows we all deal with exercises and mobility. So now we don't have space. We have to see that we are confined to a space, we are confined to a room, we are confined to a ward. So mobility restrictions for both, even for patient, he has to not go anywhere outside. We cannot take him to open air or corridors to make him walk or do. So mobility restrictions for both of us. He is bedridden, we are stuck. We have PP kits, everybody, and in PP kits to perform those Herculean tasks, to make them exercise, to demonstrate exercise. That is a big challenge for both of us, even for patient to do it and even for physiotherapists to demonstrate it. Then redesigning standard protocols. We have protocols laid down for each and every activity, how it is to be done and what is to be done, depending on his assessment. If he is performing, suppose we do preliminary assessments, I'll be dealing what assessments we do. Based on his assessments and functional capacities, we have different protocols. So we have to redesign them based on his, again, individualized protocol. If he is having some cardiac issues or pulmonary issues, how to deal with him, looking at his functional capacity, how to modify those protocols. Reassessing outcomes. You have to, suppose I have said at this entry level, suppose the patient is coming, I have assessed him on day one at entry level. So I have fixed some goals. No, I have to see this, that patient doesn't deteriorate. Whatever functional status he has, he maintains it or he improves it. He doesn't deteriorate. So when we are done, we have started with some sessions. We have to keep on assessing. Are we maintaining that thing? Are we improving or we are deteriorating? So we have to keep on reassessing our outcomes. And main hazard is that breathing exercise. We have, sir might have told other speakers, this is once we are in an aerosol generating environment and we have to face that. When we go and try to teach our breathing exercise, we have to ask patient to remove mask and take deep breaths. Mask itself is acting a barrier, and the resistance offered by mask during expiration and inspiration is also one of the factors which is causing a resistance to his breathing pattern, and that he tends to breathe shallow. Shallow breathing itself is a very big issue in these patients. We don't want patient to go for shallow breathing patterns, which will again lead to lung infections and having atelectasis at basal zones. So what our goal? So first, as I told, that there is a mental challenge, there is an issue with, so we have to reduce his anxiety and apprehension. That is, I'm a COVID positive patient, so I will be going on oxygen, I will be needing ventilator. He might be seeing other patients, somebody, every corner and every road, every street, nobody speaks of a cricket score now. Everybody, all are so literate and everybody is so interested. What kitty score hota? Okay. Tuja kitty hota? Are maze evada hota? Kon marke. So everybody has that attitude. So it is not so. Everybody is very much literate now, and rather than consoling, the problem is here. We had a lecture earlier here, and of a good psychologist. He told that our system works on a scaring mechanism rather than consoling mechanism. Upon bhiti dakhun just a treatment kardo rather than telling him that nothing would happen and this would work. So we have to change that attitude. Tell him that nothing would happen, and this is a part of parcel of your body itself has that mechanism that it will take over. To restore normal respiratory patterns, as I told, wearing mask and having that restricted environment, it will apprehension, anxiety will change your respiratory pattern. You are scared, you try to breathe faster. The mask is offering resistance. You trying to breathe shallow and fast, and plus apprehension of COVID. That environment creates so we have to relax the patient, make him restore normal respiratory pattern, promote relaxation by some techniques. Restore functional capacity. We know we have a prescribed formula based on his age, height, weight, what is his normal functional capacity should have been. So see to it that he restores his normal functional capacity. We should have goals fixed at the entry level. So, and then this is very important, man. Reduce the demand of supplemental oxygen. We should see to it that the patient who is coming walking to you rarely goes on oxygen, and plus it is on O2, rarely goes on a ventilator. We have to set that goals. See to it that minimum of oxygen after some amount of flow or some limit amount, it becomes a drug. And that addiction of oxygen is bad. And it has its own advantages, it has its own disadvantages. At some limit of time, if you keep on, because I have seen, if you, all the government officers here and other speakers are very much expert experience, they might be knowing that recently government has conducted audit at various government big hospitals that how is oxygen utilized, and we have many reports that there was a misuse of oxygen, over oxygenation of patient, which has created so many problems. So we have to see that there is a judicial use of oxygen when patients are in COVID. Over oxygenation by just by we have to be very strict in delivery of oxygen. We have to see to it that whatever is essential requirement, because no one wants to give that time. Maybe it is burden. I understand we have a lot of burden. We have a number of patients. No one wants to have that much time with that. But we have to see what is essential oxygen required for the patient. We have to taper it gradually and see what is minimum required should be given to him, so that we don't inhibit his respiratory center. By giving him excess oxygen than required will take away his efforts to breathe normally. So reduce the demand of supplement, improve his exercise tolerance and activity levels, maintain lung hygiene by giving various exercises, using various techniques, maintain lung hygiene, avoid deterioration from existing level of fitness. As I said earlier, we know him that he's coming walking. We have to see that he keeps on walking or improves it rather than going to sitting and sitting to sleeping. Then avoid ill effects of hospitalization. As I told, he has an attitude. We have an lie down. Lie down for 14 days. Why he has to lie down? He can walk, he can talk, he can do all the activities. Let him do it. Let him do it. Anything than lying is better. Let him sit, let him stand, let him do whatever he wants. But anything. The worst position is supine. I will be coming to positioning. The worst position is supine. Reduce need for assisted ventilation. Let him breathe normally. Give him various techniques to see that he breathes normally. Improve post-extubation. If he was on venti or he was on supplemental oxygen, see to it that his post-extubation parameters are improved. Main aim is to reduce his hospital. See to it that he is recovered as early as possible. He goes home as early as possible. And prepare for a healthy and functional discharge. This is very important. We just stick to our protocol. 14 days over, take, chalo. No. Is he ready to go home? Is he able to do his activities independently? Because he will be dependent on somebody. Now, it is not like earlier there were joint families. People used to be helping. Now, nuclear families, all are working class people. And everything, economy going down. He should be able to afford some health care or some aid. If it is not there, then he has to go. So is he ready to go home? So we have to see that whether the patient is healthy and functionally well to go take discharge. So it is nothing different. It is usual business, but in unusual times. We are not doing, and nobody is doing. None of us is doing extra. We are all doing our job, what is taught to us, what is essential to the society. But the times are not same. This have come after 100 years. After General Sadanand told yesterday that after Spanish flu, 1918, it was for 2 years. So this has come after. We have not faced. We were not prepared. Though we have learned, we have read, but nobody was prepared for. So this is a usual business. We are doing in unusual times. So what are our goals? So we should be very thorough with history. What are his symptoms? We should categorize properly. We should know his scan scores. We should look at his chest X-ray so we know what is affection, what is the level of affection, which zones are affected, because positioning matters. I will be dealing with positioning later on. So, as many of authors believe, many of the specialists believe that we should not do any activity which is aerosol generating, but we don't have options. We have to do it. So we have at this COVID center, we are having pulmonary function test done earlier. So we know what is his exact capacity. So whether he is deteriorating, whether his vital parameters, whether his expiratory flow rates, inspiratory flow rates, what is affected. So we know it. So we can concentrate. So as it is a part of having goals fixed, what is his issue? We cannot generalize. Based on score, I cannot go. Yeah, he scored, so let's start. No, we should know. And then we have some 6 minute, we should do this 6 minute walk. Whether he is able to do a easy quarter movement, 6 minute walk test comfortably. If he is able to do it, We know his parameters, how is his cardiac response, how is his pulmonary response to activity, and other activity levels. We have to monitor them. So what are our treatment techniques? What do we have here? So we have various techniques to be done here, like breathing techniques, breathing exercises, chest expansion exercises. We have bronchial hygiene techniques. We have dyspnea relieving positions. We have simple nebulization. Everybody knows what nebulization is. We have general mobility exercises. We have body positioning like proning. Everybody is using. There is much now, very much literature available. It has come, mainly it was practiced in ALI and ARDS. This thing came from European studies that acute lung injuries and ARDS, mainly this body positioning was tried. And then there is assistive devices where we can use respiratory assistive devices, and we should go ahead with it. So we start with our breathing exercise techniques. It appears very simple. What extra we are giving? Everybody is breathing. You are breathing. I am breathing. Patient is breathing. So what extra we are trying to achieve by just telling him to do breathe? No, it is not so. It may appear simple. Everybody may feel that it is just breathing in air and breathing out. It is not so. It is a defined technique. Patients, as I told earlier, there is apprehension, and the normal breathing respiratory pattern is lost because of stress or apprehension or anxiety. So we have to teach him. We have to use the primary muscle of inspiration, that is diaphragm. We have to teach him what is relaxed breathing, what is diaphragmatic breathing. A therapist will be placing. We will be demonstrating after the session. We will be demonstrating this. So relaxed diaphragmatic breathing is there, which will improve his tidal volumes and promote lung expansion. And then there is segmental breathing, costal breathing is there. We use the segmental breathing. Hands are kept basically to tell or make patient understand that where you have to force, where we have to concentrate, that the zone has to expand. So there are a lot of literature available. Good articles have come up with this, that simple breathing exercises can have a lot of tremendous effect. If you read in Times of India, also have given a coverage regarding what is the importance of breathing exercises. So as it appears so simple, but it is not. It will improve your ventilation. You have to first relax. You have to tell him to breathe. If somebody is breathing at an RR of 18 and 20, so he's breathing shallow. We have to have a normal respiratory rate of 12 to 14. Ask him to relax, take deep breaths. Deep breathing will improve his cough mechanism. It will prevent pulmonary impairments. If there are secretions retained, if there are some attenuatory zones occurring in basal, we will open them up. Collaterals will open, and there will be correction of abnormal breathing pattern or inefficient breathing pattern. Patient will learn to how to deal with shortness of breath attacks. Relaxed breathing will promote again relaxation, and it will help in overall improving the functional capacity of patient. Simple again, chest expansion exercises. It appears very simple again. Patient has to sit in chair. We have incorporated earlier when we started COVID care center here. Everybody used to lie down. Then we requested the hospital team, and they were very much positive. Yes, they agreed to everybody, and we saw to it that the chair is kept next to the bed. We saw to it that patient sits nearly for 8 to 10 hours, and patients were also happy to sit in chair rather than lying down on bed. Otherwise, everybody sitting, lying, reading, everything was on bed. So they started sitting. By sitting, we improve the lung functions. As I told, anything better than any position is better than supine. So by chest expansion, you improve your thoracic mobility. You have your capacity is improved. Simple raising hands above head, at the sides, taking behind, will improve your chest expansion exercises. This is a very good article from Australian journal, which totally gives information regarding all the small exercises, how they play magic and work wonders. And so what chest expansion will do? It has a combined role of active movements of trunk and extremities with deep breathing. You coordinate, you're just breathing now, and you just breathe with open hands. You will definitely feel that rush of air and that additional air you can breathe in. It is designed to maintain and improve mobility of chest wall, trunk and shoulder. We don't want patient to, as I told, we don't want to restrict them. They should be mobile, they should be ambulating. So it will improve the chest wall mobility, trunk and shoulder mobility. Then exercises they are combined with stretching and deep breathing will improve the ventilation on the sides of the chest. As I told, if we can add it, it is just upper extremity. We can have turning, we have rotations. There are multiple exercises in this which can be done. And mobility, we don't want patient to restrict by just sitting in one posture and having that restricted pattern. So he will basically open up the thoracic cage and have good chest and trunk mobility. There's something you might have been seeing that this is in ICUs we commonly practice, like bronchial hygiene techniques. Here we have postural drainage, we have percussions, we have vibrations, we have cuffing and techniques, and we have suctioning techniques. This is commonly practiced in all standard ICUs. So this is what is the postural drainage based on the lung zone or lung area which is affected. We use gravity to assist in drainage of the secretions. We have designed some tables, or we can use it on bed also, depending on the which zone is affected. So X-rays are important, and you should have that knowledge of auscultation. We should not fear that patient is, how do I auscultate? No. Good auscultation is very important for COVID patients. Which zone is affected, we need to know. And based on which zone and which area is affected, the postural drainage positions have to be given. And once the patient is positioned in that typical position, which zone is to be drained, then we use techniques like percussion and vibration, which will help in loosening the secretions and moving them more centrally towards the trachea, and they can be easily cuffed out or removed by suctioning if patient cannot cuff effectively, or then he can cuff it out. So what is postural drainage? It will improve the clearance of secretion. It will improve the homogeneity of ventilation and gas section. Ultimately, we have to see that lungs remain clear. The main goal, mainstay of this entire scenario or chest therapy is to see that lungs remain clear. We have to see to it that his functional capacity, based on his earlier demographics, that is height, weight, and body age. We have a prescribed format in PFT that this should be his PFR, this should be his vital capacity, this should be his flow rates, this should be. So based on that, we should see to it that we maintain it at least above 80%. So we have to see that his airways remain clear. See, if secretions start accumulating in basal zones, they will tend to have infection. Zones will try to go into collapse, pneumonia, and other parameters will set in. Again, they will try to have infection. Infection will invite more complications. So mainstay is again improving the clearance. Percussion, as I told, percussion is a hand simple technique with which we give by patting the area. It will help to loosen the secretions from the bronchial trees, and they will be easily removed by cuffing and suctioning. And vibration should be used when we want to centralize the secretions from the peripheral zones. The main aim, again, to reduce the secretion retention, which will, once they are cleared, it will improve the oxygen exchange, and it will improve the collateral of the lung, which will reduce the work of breathing and reduce the demand for supplemental oxygen. Simple dyspnea relieving positions are there. These techniques are there, by which, again, the Times of India had given a good coverage on September 13th, 1 year back, how the simple techniques would help us in relieving the dyspnea of patient by performing simple exercises. So there are various positions. There is something called as pursed lip breathing. Pursed lip breathing is nothing but just you would try to breathe against a small resistance, which generates a small positive expiratory pressure throughout the lungs, which will help in clearing the secretions and opening up the collapsed airways, or in having the retained secretions removed. And there is a stack breathing pattern even. This is a simple, if patient is dyspneic or having some breathlessness in wards while walking or on lying, by just forward leaning, sitting, or high side lying, or forward lean on a chair, or standing with back support to a wall. What this will support the rib cage and accessory muscle structure, and will help in relieving the dyspnea. It will give a support to upper thoracic cage and will help in proper utilization of respiratory muscles. Pursed lip breathing, I told, just by pursing the lips like a fish. If you try to blow out a candle or a paper, it is what we are trying to do. We are trying to offer some amount of resistance to the expired air, and it just generates a positive, creates a positive expiratory pressure throughout your airways, which will help in removal of secretion, or it will take away your breathlessness. And stack breathing is old technique which has been used. It is just stacking means you're just taking a breath over breath. Now you're taking some volume, add without expiring, take one more breath, take one more breath with. So if it is an X breath, you add X plus 10, X plus 20, X plus 30. So it helps to open up all the alveoli, all the dependent zones which are affected here. So it will help to open up all the channels. It will again reduce your work of breathing and improve your oxygenation. Many studies have been done in this, and this is very effective technique. Though it appears very simple, we are just asking to do, but it is very effective. We have been using in cardiac surgery and surgical cases. So what are the physiological benefits of this pulse breathing exercise? It will release shortness of breath by slowing breath rate, keeps airways open longer, which will decrease the work, and that goes into breathing by lowering the EPP. There is something called in physiology equal pressure point. So which is higher centrally, will try to move distally and improve the channels, improving ventilation of moving out old air and trapped into lungs where new air can go in. The stack breathing will improve your depth of breathing by recruiting the collapsed and athletic zones. It will aid in removal of secretions by opening the collaterals, and it will help in rib cage mobility and flexibility and improve the cuff strength and effectiveness. These are general mobility exercises. Those patients in mild ward, they have nothing to do. They're just observed, monitored. Ask them to get out of bed. Ask them to do some chair exercise, open exercises. Very simple exercises. Has a lot of. This is our COVID center. These are not taken from internet. This is my COVID center. This is my staff doing all these exercises. You will see all the patients on O2, even patients on NIV. We have made patients to stand. This goes a long way. The patient who is on NIV, last right side lower end photo, patient was on NIV nearly for I think 15 to 20 days. Yeah. It was nearly for 15 to 20 days patient was an IV, but we saw to it that daily morning we make patients stand and at least do some limb exercises, and patient went walking home. Patient's age was 73, score was something around 18 plus. So this has a role, this does have a role, and which helps in mobility and preventing. See, lying down and recumbency itself has its own complications. There are many articles cited in good journals, standard journals, which have cited the effect of early mobility for all the cases. Benefits are it will increase efficacy in respiratory mechanics. It will increase the stroke volume of heart and improve cardiac output. It will reduce the peripheral vascular resistance. We know patients have clotting issues in this disease. We don't want patients to go into those issues. We don't want to have patients have PVDs and all those things. So we should see to it that it will reduce those risks. It will improve the blood flow to all areas, improve peripheral tissue oxygen extraction, improve the functional capacity, have a number of ventilator-free days, and reduce the ICU acquired weakness. Increases arousal. So many, again, Times of India highlighting those issues. See what is the impact of this. Is nothing. This is again taken from Times of India. They have also emphasized. They were more keen to see that people remain mobile. Increases arousal, cerebral activity is improved, stimulus to breathe, sympathetic stimulation. Any activity which has an effect on your heart rate and breathing should be done. If you say exercise is an activity. Exercise is not a simple doing hands up and hands down or getting up and. If an exercise or any activity doesn't increase your heart rate or breathing rate by 10%, is of no use. See to it that any activity you do, walking, you do jogging, you do cycling, whatever you do, it targets your two values, your heart rate and your respiratory. If it doesn't change from baseline, if you don't try to breathe more, or if your heart rate doesn't change from baseline, that exercise is not going to help you. Body positioning, much discussed topic, lot of publication, lot of articles, lot of discussion, lot of photos, lot of social media on this. Keep patient lying prone, and this is being used. Yes, it does have, but it is very simple and beautiful physiology behind this. Nobody is playing magic here, or nobody is doing some magic. It is just simple first year physiology which works. We all know that we have evolved from 4-pedal to bipedal. We all were on our 4 limbs, and then we came to 2 limbs. Everything evolved, but then the lung is yet to evolve. Though it has evolved functionally, but then structurally it has not evolved. If you see lung, the upper diagram which is shown in supine, the size of lung is more posteriorly. It is extending caudally. It goes till lumbar vertebrae posteriorly. alveoli in the posterior zones are more. The volume of air which is in the posterior and dorsal zones of lung is more. So we just do. So when patient is lying in supine, what impact it has? The heart has an impact of, as it is anteriorly, it has impact on compressing the lungs. So you have an already patient is compromised. He has his own problems with COVID. The heart is overall compressing. When you are in supine, the heart has a small effect of compression. Plus, your abdominal organs tend to slide up. The liver and intestinal organs will come up. If you see the position of diaphragm, it will try to push diaphragm more into the lungs, into the thoracic cavity, where your excursion of diaphragm is reduced and patient tends to breathe shallow. Your vital capacity comes up. We are just asking the patient to go prone. What is happening while going prone? The burden of heart over lungs is gone. Plus the organs of intestine which are pushing the diaphragm into the thoracic cavity, the burden is gone. So your diaphragm is free. It can excurse more. You can breathe more efficiently. Plus the zone of lung which is more posteriorly, if you see, it will have more impact in ventilation. Now that zone which is dependent zone has become active zone, where we know zones of lung. I will show it in next diagram. Yes. This is from first year physiology, the West lung model. If you see if an isolated lung, we start from the left side diagram. This is called, these are the common alveoli triangle. Now, this is patient in supine. The uppermost ventrally, if the alveoli will open more. See, in physiology, first year physiology, we see to it that the uppermost is ventilated best, while the bottom one is perfused best, while the middle zones have both the things equally. But here, if patient is dependent on in one position for a long time, after some amount of time, with the effect of gravity and recumbency, the basal zones, if you see in diagram third, say, the alveoli tend to collapse because of the fluid pressure and things. And the upper zones are only one which are participating in the ventilation, while basal have already tend to go small, and there will be less air entry, less air entry, and not participating in COVID means that's right. Means they will tend to accumulate secretions and they will not participate in activity. You are asking now in the second three diagrams, you are asking them to go prone. See, the basal zones have started opening up here, and after some time, there is something called as shape matching. All the alveoli will participate here in the ventilation. This is simple physiology which plays wonders. A lot of articles, again, good articles. This is not now. This is since 80s and 70s. Good articles have come. The first article was in NEGM, in ARDS. Good article was given. So things work in proning. See, this is again at my center where we have done. We have actively seen a patient. Senior female lady was on OT. We requested them, and they felt. Forget about me telling or you telling. They have felt the change. Whenever next day or after doing that, we used to see patients putting newspaper on chair and lying down prone and reading it. We saw that patients used to do it happily. They used to do it happily, and they really improved faster. This is the patient on O2 on the left side, and on right side, patient is on NIV in prone, positioned in prone. As I told, this will improve the patient's oxygenation and include the recruitment of non-irritated dorsal lung territories, that is postal, the areas of lung which are not ventilated. It will improve ventilation perfusion mismatch, improve the CO2 clearance due to increase in number of open and ventilated alveoli. It will have a homogeneous distribution of lung parenchyma and reduce the risk of VLI, really, that is ventilator-induced lung injuries. Because see, if a patient is lying down in supine for a longer time, and that if the dorsal zones tend to collapse, we have set pressures on ventilator based on his height, weight, and all those. If those zones don't open up, it will increase the ventilator pressures, and those increased pressures will cause barotrauma or other lung injuries, which we want to avoid. We have to have that lung expands, homogeneity of lung is throughout the lung parenchyma responds to everything. It will improve the lung respiratory mechanics by reducing the airway resistance. By putting prone, you have that airway in a draining manner. When you put patient prone, the zones by default come into draining position. If there are secretions, we have seen intubated patients putting prone, the secretions were already found in the tubes. With small efforts of chest fill therapy, already they start mobilizing very well in prone. It tends to have a draining effect there. It improves the saturation and SpO2. And this position really helps in reducing the demand of supplemental oxygen. This, as I told, this is one of the major goals we have to have. That how does it work? Then respiratory, those patients were on without on not on venti, but can do some exercise. We use incentive spirometers. We have oscillating PEP devices, vibrators, and inspiratory muscle trainers, which can be used. Everybody has seen this. Everybody has used this as a common incentive spirometer, which is used everywhere. These are other a cappella, which works on positive expiratory pressure theory. As I've told, by improving, offering resistance to the expired air will help to improve collaterals. By improving collaterals, you improve the ventilation to the dependent zones and help in removing the secretion. This is flutter, which helps again, works on the same mechanism. Again, good articles we see which help in improving. This is IMST. This is we have started using this more frequently here. Patients, as I told you, see, why do we breathe? There is a stimulus. CO2 acts as a stimulus. We know that after some amount of time, there a CO2 level goes to some level, and we know that we have to breathe in oxygen. And then, so if you keep on giving supplemental oxygen at higher levels, patients' inspiratory muscles go weak. Plus, patients on BiPAP, we have seen many patients here on BiPAP for a longer duration had weak inspiratory muscles. They were not able to breathe. We were not able to. His lungs were becoming clear. They were responding to drugs. But why are they not going for that trial? Means they were. Whenever we tried to remove or we tried to lower the pressures, patients were becoming panicked. The vitals used to shoot up. So we performed this inspiratory muscle strengthening test, and we saw to it that muscles were going weak because they were on positive pressure for a longer duration or using higher, which will take away the stimulus to breathe normally. So then we started inspiratory muscle training for those patients. So by intervening between, and then we need to give inspiratory muscle strength training, and after this, they could easily be weaned from this. And as I told, we cannot categorize generally by mild, moderate. We had multiple categories of classification, like category 1 for us. For our intervention was asymptomatic patient with mild category as per you, who was ambulatory and non-O2 dependent, while 2 was asymptomatic mild, non-O2 dependent, but he used to desaturate on ambulation. So a walk test, we told you, we used to do a walk test. Or category 3 was symptomatic patient, but on moderate O2 dependent, who required O2 but on mask. Again, 4 was symptomatic with severe O2 dependency on either NIV or HFNO. And 5th was symptomatic, was critical, either had acute lung injury, ARDS, or multi-organ failure, and severely O2 deficient. And then based on these classifications, we had our goals and we have had our treatment modalities as discussed. For one that we said earlier, those were asymptomatic, mild, and objective was to improve ventilation, maintain their functional mobility, and prevent deconditioning in those patients by just making them not to lie down for. So positioning, bronchial hygiene, we used to teach them self by doing self. Deep breathing exercises, chest expansion exercises were taught, upper and lower general mobility exercises were taught, and bed in and bed around mobility was taught to them. Group 2, as I said, those who were to only desaturate on ambulation. Again, we had to improve their exercise tolerance with all other aims. So again, positioning, we here ask them to go for positioning, bronchial hygiene techniques, again breathing exercises with chest expansion, upper limb and lower limb general mobility exercises, and bed in and bend around mobility exercises using oxygen. We had a moving oxygen cylinder. We used to see, he's on oxygen and he should not know. We saw to it that he will walk in corridor, he will walk the given length with a O2 stretcher behind him, and we made him walk. Third group, who was on O2 mask, again, all these activities, plus improving exercise tolerance, we saw to it that, again, all the interventions were given, but here monitoring was essential. As he was O2 dependent, monitoring was very essential. Those on NIV, as I showed you a photograph of patient who was on NIV, we made him stand and we made her walk even with support. Again, maintaining lung hygiene, improving airway clearance, reducing the work of breathing, we are maintaining and improving the functional capacity, monitoring and prevent deconditioning. All the interventions as discussed, awake proning, dyspnea living positions were taught, nebulization was intervened here, bronchial hygiene techniques were required here actively, chest expansion and mobility with NIV, as I've showed you. We made patients stand and walk around bed. That is very important to prevent deconditioning. And those patients who were basically sedated for management, we had to maintain the lung hygiene and improve clearance. There were good amount of patients inside, and we saw to it they were extubated in time and they went home successfully. So maintaining lung hygiene, improving air clearance, reducing the need for supplemental oxygen is very important here, and preventing deconditioning. As patient is not doing actively anything, we have to intervene here and go for proning and passive exercises. Here the therapist has to perform the role. Here we have to see to that we mobilize mobilize our upper limb and lower limb to maintain the functional capacity. This was a book published last year by one of our work groups, and this was circulated. This was physiotherapy management in COVID for Indian setup. I was one of the contributing authors for this book, and we have discussed all this management. The key message for this topic, I will tell you that here early intervention is very important. We cannot just label patient COVID and lock him in. No, that is not done. He has to be mobile and as functional and as ambulating as he can do. And COVID-19, we are just speaking. I've just spoke about lungs here, as I belong to Department of Respiratory, Cardiorespiratory. But it is beyond lungs. We will be seeing more patients of post-COVID coming now. I've seen many patients coming to physiotherapy OPD, orthopedic OPD with AVNs, lower limb backache issues, lower limb joint pains and all. So it is beyond this. Many of them are coming to medicine OPD for many other issues. And discharge in patient is not done. Discharging is just the beginning, I'm telling you, for post-COVID rehab. Once he goes back, the thing starts from there. He has to adapt to everything. He has been in lockdown, so he has to adapt. And with his, I don't know what amount of, based on his scores and his functional capacity with what he goes back. So that's what I told you. Mainstay is to see that as much as less damage is done to the patient and he goes more functionally. So we have to prepare patient for his social adaptations and his home environment adaptations. So it is just the beginning. Discharging patient is just beginning of his rehabilitation. He has to adapt to his social needs, his family needs, his job needs, and everything. This was my team who was very much active during COVID period. Thank you so much for your patience during this session. I thank everyone for giving me opportunity to speak. And if anybody has any queries, I'll be grateful to answer them. Please feel free. Thank you so much.
Thank you so much, sir, for giving us your valuable time and a wonderful insight on physiotherapy in COVID-19 care. So we have come to an end of our morning session of our awareness program in medical fraternity on COVID-19. Please join us back at 2:30 p.m. for our afternoon session. A very good afternoon. A very good afternoon to everybody. We'll start off with our next lecture for the day. Next, we have Dr. Prachi Anshavle, Madam. She's an associate professor in the Department of Microbiology at Dr. Vittal Rao Vikhe Patil Foundation's Medical College and Hospital. Welcome, ma'am.
Good afternoon, all of you. As sir has already told that I'm going to speak on the infection prevention control and biomedical waste management in COVID-19. I'm from the Department of Microbiology, and I'm firstly thankful to Dr. Avari sir, HOD Microbiology, for giving me this opportunity. So as all of you must be knowing that infection prevention is as important as treating the patient. So I'm going to focus on this important topic for management of the important pandemic which is occurring. So our learning objectives are firstly, we are going to brush up all the things that we'll firstly revisit the ways of infection spread of COVID-19. Then we'll see what are the preparation and implementation, how we do preparation and implementation of infection control policies in the hospitals. Then the next important thing is biomedical waste management, which are related to COVID-19. So brushing up the important thing, as we all know, there are different sources of COVID-19. First is air. The virus is known to stay in air for 30 minutes and it can infect the passerby if inhaled within those 30 minutes. So these are the basic things which we all know. Then it can be spread through the surface contact. If infected person touches any surface without proper sanitization, others can be infected by touching that surface. Then the next important mode of transmission is droplet transmission, in which the aerosols and droplets from nasal or oral discharge due to sneezing, coughing, or even speaking can contaminate air and the surface with the virus. So basic thing, how to prevent the infection and which are the different control strategies. So in infection prevention and control strategies, there are 5 important components. First and foremost is the early recognition of the source control. So it is very important for early recognition. Then second important is standard precaution. I'm going to talk about each and every point in details about that. Then next important point is the transmission based precautions. So the precautions which we have to follow, there are 2 types. First is the standard precaution and then transmission based precaution. The next important is environmental cleaning and disinfection. We are going to talk about the hospital environment only. We are not going in details of the domestic environment as such, but we will talk about more importantly hospital environment, and finally biomedical waste management for COVID-19. So in early recognition, the strategies which we follow for early recognition and source control is firstly, we should not, once the patient is detected with COVID-19 or having suspension or having suspicion of COVID-19, first and foremost thing is based upon high clinical suspicion, the treatment should be started. So there should be no delay in treatment. And for that, awareness in public areas, reminding the symptoms of patient to alert the healthcare workers is also very important. Then promotion of respiratory and cough hygiene is as important as treating the patient. So prevention, as we always say, prevention is better than cure. So there should be cough and respiratory hygiene, and it is a high time that whole of the society should follow all this necessary hygiene, respiratory and cough hygiene. Isolation of suspected cases in an area, separate in isolation room from the other patients. So these are the basic things in early recognition and source control. So I'm going to talk more about the hospital environment. So in hospital environment, what is important is a triage system. You must be knowing what is triage. Triage is basically classifying the patients based upon their signs and symptoms, so that we can it is for for many pandemic situations in which we have to give priority to those patients who require hospitalization and who need more clinical attention and more clinical care or medical care. Therefore triage is necessary. So what is triage? Is basically sorting out or classification of the patient or casualties for that matter to determine the priority of the need and proper place of the treatment. During infectious disease outbreaks, triage is particularly important to separate the patients likely to be infected with the pathogen of concern. Why triage is important? It is not important for those patients who are suffering from severe signs and symptoms, or who are suffering from severe clinical diseases. But triage is also important for preventing the transmission of infection from those patients to the normal patient or the healthy patient. So basically, triage is one of the best method, or it can be called as a base for the management which we do in healthcare facilities who are going to provide the COVID-19 treatment facility. So what should we include in hospital preparedness? So this should be actually the plan for hospital preparedness. Why I have highlighted this slide, because I'm not going in details of each and every component, but the important thing or essential component of hospital preparedness plan includes the well-resourced infection prevention team. As you can see here, the full-time emergency manager is the first which comes in the hospital preparedness plans, who will coordinate and oversee the COVID-19 patient. Then the operation task force, obviously, and the third person who comes in hospital preparedness for such a pandemic is a well-resourced infection prevention team. Because, as I already told you, infection prevention is as important as treating the patient. Therefore, the person who is doing the infection prevention, who is present in a infection prevention team, should develop and revise personal protective equipment protocol. Why it is important? That person should take care not only of the patient or not only of the infection control of the hospital, but also the healthcare workers who are giving the treatment, or who are giving or providing all the facilities to the patient, or who are serving the patients. So develop and revise personal protective equipment protocols with backup plan in event of supply shortage. Then facilitate personal protective equipment training, provide education about transmission risk, perform exposure investigations, and track epidemiology with the hospital. So in hospital preparedness, infection prevention is one of the most important component. So how to prepare for triage? We have to triage will based upon the signs and symptoms which are present in the patient. So post clear signs at healthcare facility entrance to direct the patients to firstly telemedicine facility. Now, what is telemedicine facility? As we know, in pandemic situation, there are lots of patients coming from the society. So it is very difficult for a hospital to provide all the facility. So based upon signs and symptoms, if you are able, or if the clinician is able to provide the therapy initially, the patient is in initial phase, if the score is 0 to 2 or 3, if the CT score is 0, 1, 2, 3, then the telemedicine therapy can be provided. Why it is important? It is important for prevention of infection, because these patients, when they are coming to the healthcare facility, they are becoming the more source of infection to the other people who are also coming for the non-COVID treatment. So in such situations, in pandemic situation, the hospital should prepare for, or the institute who is giving the healthcare facility should increase or should give facility of telemedicine. So telemedicine therapy is also important in pandemic situations. Those with fever and respiratory symptoms like cough or breathing difficulty, they should immediately proceed to triage or registration desk. Why telemedicine is important? Because patient on the telephonic conversation, the patient can tell whether he's having severe symptoms or mild symptoms. If the patient is presenting with the severe symptoms, then we can immediately call the patient to come to the hospital, and with the help of this triage system, we can immediately give him the further treatment. So we can call him and get him admitted. So which are additional symptoms which tells that the patient is having the severe symptoms? So first is the fever and respiratory symptoms. Along with that, there can be chills, repeated shaking with chills, then muscle pain, headache, sore throat, and new loss of taste or smell are the important symptoms which we have to consider for admission to the hospital. Here I'm going to talk about the prevention of the infection prevention, or mainly protection of the healthcare staff. Why? Because we are the frontline workers. We are going to serve the patient. So it is as important as serving the patient to take care of yourself. So I'm going to from here onwards, I'm going to tell about the important steps or important things which we have to follow while serving to the patient, while serving the COVID-19 patients. So what are the important things? First, an important thing is to protection of the healthcare staff. So there should be installation of physical barrier, for example, glass or plastic screen. Nowadays, we can see those screens at each and every places. For example, in medical stores also, they used to have this kind of screens. So it is important, and it is important source of prevention, or it acts like a barrier. So installation of this kind of screens is very important at registration desk to limit the close contact between triage staff and the patient. Then next is to identify isolation room or separate well-ventilated room where suspected COVID-19 patients will be placed while waiting for the examination. As we all know that the major cause of second surge of COVID-19 in India, or for that matter in Maharashtra, we can say that the vaccination was started. So the vaccination and the rapid antigen test were simultaneously present, or the primary healthcare workers are simultaneously giving facilities of both rapid antigen test as well as vaccination. But what happened? The patients which are coming for the vaccination and the patients who are coming for the rapid antigen test, they were present very nearby. So this is the major reason for the surge of second wave, or it is the major reason of surge of the increase in patient in. So those healthcare facilities, they have become a hub for increased, or they have become the source of increased transmission of infection, because those patients who are coming for rapid antigen test, they are coming in close contact with those patients who have come for vaccination. And therefore, this is the major cause why we get the sudden surge of the patients in a second wave. Therefore, while those patients who are waiting for getting treated or for getting investigated for COVID-19, they should be separated from the other patients which are there or who are waiting. Therefore, there should be well-ventilated isolation room for COVID-19 patients. Then next is for all patients, even if they are not wearing masks, it is important, or it is desirable if we can provide them masks or face covers for those who are visiting the healthcare facilities. So all of these things are important for protection of healthcare workers. So these are some pictures showing the barriers and the social distancing which is maintained in the hospital environment. So that, and the next part, this thing, it is showing the ICU in which the treatment is given. So for each and every places, basic things has to be maintained. So we are going to see which are those basic things which we have to now maintain. Then next is social distancing. This we all know, and we have all followed these things, but it's just a kind of reminder I'm giving you that social distancing has to be followed at each and every places. So this is a setting up triage and waiting area. So if the patient is coming here in the waiting room, in the registration area, there should be different places for regular waiting. There should be different places for respiratory waiting area. This So therefore, these patients will be isolated from those patients who are coming from the coming for getting treatment other than the respiratory symptoms. So there should be clear isolation or clear distinction between these two types of patients. So ideally here also the patient should wear mask, and here patients are already wearing masks. So this is basically a picture showing the ideal environment or ideal registration test of the hospital who is providing healthcare facilities. So there should be outside the triage area, there should be signage direct to the patient to different areas based upon the symptoms. So there should be clear instruction where the patient is supposed to go. If the patient is having respiratory symptoms, they has to be isolated, or they should go by other direction. And those who are having non-COVID symptoms, they should be properly isolated. So those patients, we are talking about the COVID-19 patients. So those patients who are having the symptoms, they should be placed in 1 meter distance between all these patients with mask, and after that they has to be isolated, or it is ideal to provide them a area which is well ventilated. Therefore, this is our tent which is showing that it is ideal to separate the patients of COVID-19 who are suspecting COVID-19 symptoms in a well ventilated isolated area than the patients who are coming for other non-COVID symptoms. So protecting healthcare workers at triage, how to protect ourselves as a healthcare workers. All healthcare workers performing triage activity should adhere to standard precautions at all the times. And these healthcare workers should have convenient access to hand hygiene for all the time. Healthcare workers conducting preliminary screening that does not require direct patient contact should maintain at least 1 meter distance with PPE, that is while handling or while getting contact or having contact with the interviewing the patients. We should maintain at least 1 meter contact with the proper PPE. These activities includes interviewing patient about the symptoms, exposure, or taking temperatures with non-contact infrared thermometer. So it is ideal or desirable to have 1 meter distance between the patients and us with the PPE. Healthcare worker conducting physical examination of patient with respiratory symptoms should wear gowns, gloves, face mask, and eye protection. That is the whole PPE. This all thing we know. Now, how to don and doff the PPE. Donning is putting on all the PPE. PPE is personal protective equipments for the healthcare workers. So there is a particular sequence for all the healthcare workers while putting on and removing the PPE. So before donning, that is before putting on all the personal protective equipments, healthcare workers should put on scrub, ensure hair is tied back securely off the neck and the collar, remove jewelry, pens, ensure that, and not only that, but ensure that you are well hydrated and first perform well hygiene. So before putting PPE, it is also necessary to take all the precautions and be hydrated. Take plenty amount of water before putting on PPE. And so there is a sequence of donning or wearing of PPE in the form that while putting the PPE, first gown should be wear, then gown first, after gown, mask or respirator, and it is confirmly or definitely we should use N95 mask and not other than N95 mask for as we are giving or as we are serving in a hospital environment. Then after mask or respirator or N95, goggles or face shield, and finally gloves. If you are putting two pairs of gloves, then it is recommended that you have to put first pair of glove before putting the gown. So first pair of glove, then gown, then the respirator, then goggle or the face shield, and then finally the second pair of glove or the first pair. Okay, so this is the sequence of wearing or putting on PPE. The next is doffing, that is taking off PP. It should be removed in an order that minimizes the potential cross contamination. So the sequence of doffing is first the outer pair of gloves, first, then the face shield or the goggles, then gown, and finally mask. So it is recommended that first, the important thing in this is that discard PP in appropriate biomedical waste bin. So I'm going to tell about different types of biomedical waste bin and what should be placed in which type of bin. And what is important is all PP should be removed just before exiting from the patient's room, except for a respirator. So it is necessary that you should doff or you should put off all the PP before leaving the patient's room. Okay, but you have to maintain the distance of 1 meter before doffing. You have to maintain the distance of 1 meter. You should doff all the PP except for respirator in that room only. Why? Because those are carrying lots of viruses, or there is lot of viral load on the gown and the face shield and the outer pair of gloves. So it is recommended that except for respirator, you should wear off all the PPE in that room, keeping the distance of 1 meter from the patient, and then only keep the respirator or only keep N95 mask, and then you can exit from the room. Okay, you can remove N95 mask after coming out of the room, but it is necessary that you should discard before leaving the room all the PP. This was about the putting on and that is donning and doffing of PP. Now we are going to see what we have to do or which precautions we have to follow in handling the patients. So isolation of suspected COVID-19 cases. Patients who are identified as suspect of COVID-19 cases through triage process, they must be separated from other patients as soon as possible. They should be given face mask and ask them to put it on. If the face masks are not available, patients should cover their mouth with a cloth. Place the patient in single person room with the door closed. It is recommended, or it's an ideal situation if the patient is having symptoms or confirmed with COVID-19, he should provide, or that patient should be provided an isolated room, well ventilated isolated room. But of course, it's an ideal situation. If single person room is not available, then designate a separate well-ventilated area for these patients and ensure that they maintain 1 meter separation from each other. So if giving separate room is not possible, then at least 1 meter distance should be there for between each and every COVID-19 patients. Only essential healthcare workers designated to care for suspected COVID-19 patients should enter the isolation area wearing appropriate PPE. So the entry should be restricted, even though all the healthcare workers, though they are trying to serve the patient, or all of them are there for serving the patient, but healthcare workers should be clustered. That means the entry to that particular COVID-19 isolation room, the entry should be restricted to particular healthcare workers only. This is necessary for cross contamination or cross transmission of infection. Why? Because it causes a burden. Those healthcare workers which are entering in the hospital, they have to wear proper PPE kit and all. Therefore, if we do not restrict the amount or the person who are entering into the healthcare facility, if we do not restrict, then it can increase the burden on the hospital management, and thereby there can be chances that those who are serving the patient, they may they will not be provided, or they may lack the proper PPE kit. So the person who are going in those areas, the number should be restricted. Ensure that healthcare workers caring for the patient in isolation area adhere to standard contact and droplet precautions and follow the strict donning and doffing protocols. So how to do inpatient care strategies for COVID-19? Initial cases should be admitted in airborne infection and isolation rooms. Then cohorting isolation room or the ward. So there should be separate area for those patients who are suffering from the respiratory symptoms. Then cohorting in specific units. So the wards, the serving unit, they should be isolated and separated from the other hospital environment. The units and floors converted to cohort units. That is the same thing. That is, we have to dedicate specific area of the hospital to those patients who are those patients. Then designated units may be needed for non-infectious hospitalized patient. So we are more focusing on COVID-19, that as we have faced a very worst condition of COVID-19 second surge. But in the same case, for the healthcare facility who is giving facility, there should be a separate area or a separate place for those emergency non-COVID patients also. Why? Because we cannot neglect those patients who are not suffering from COVID-19. Still, they need some emergency care. So, therefore, there should be separate designated area for those patients also. But the important thing in this is that you need to revisit your admission plan based upon the case surge at your facility. So this is a general guideline which is given. It can change from time to time based upon the conditions which are present. So which are the care strategies? Emergency departments often operate at or above the capacity on the daily basis. I think you must all be knowing that in second wave, all the emergency departments were often operated above the capacity only. So, in addition to above strategies for outpatient care, emergency department should consider diversion of non-critical possible COVID-19 cases at a triage point prior to emergency department entry. It is also called as parking lot triage. That means in COVID-19, again, we have to do triage thing. Those patients only which are needing, high, like those who will need, you suspect that they will need intubation or they will go on BiPAP. They should be isolated in a specific different area than the routine or those which are only on oxygen therapy and all. So parking lot triage, that means we have to prioritize those patients' admission, and then accordingly we have to give the treatment or we have to get them admitted in different units of the hospital. Use of specific places like urgent care, pediatrics, same-day surgery for COVID-19 patient, subject to appropriate isolation of the patient, that area from air handling and patient movement standpoint. So what I mean to say that along with COVID-19 patient, those who are coming for non-COVID symptoms on the emergency basis, like for same-day surgery or pediatric cases or for emergency cases, there should be a dedicated separate area in the hospital for giving the care, and the both areas should be completely isolated so that we can prevent the transmission of infection. Coordination between emergency medical department, including through telephonic triage to avoid emergency visit that can safely be cared for as an outpatient. So outpatient in emergency or pandemic situation can not only by giving outpatient facility in the care, but also, as I have already told you, that telephonic medicine or telemedicine, in other words, the facility should be provided by the healthcare workers. Patients should wear simple flexible fabric mask to reduce the droplet generation unless wearing an oxygen mask. If the patient is not wearing oxygen mask, then always the patient should be wearing fabric mask. Intermittent rather than continuous oximetry and cardiac monitoring must be instituted with separate for each patient. So regular monitoring of the patient is needed. Use inhalers in lieu of nebulized medications to reduce the droplet generation. So while nebulizing the patient, the respirator should be like that, or nebulizers should be like that. Minimum aerosol production should be there. So while giving nebulizers to the patient, it is important for prevention. It is important for droplet prevention. Then coordinate with critical care physicians regarding threshold of intubation, use of bridging techniques, for example, high flow cannula or BiPAP, then requirement of special area and augmented PPE for providers given at the higher risk of aerosol generation. So the area where there is high aerosol generation is area where basically in ICU. So what happens in ICU, you must be knowing that there is continuous suctioning of the patient. Suctioning itself generates high amount of aerosol production, or the patients who are coughing a lot. So they are also a major source of aerosol production. So for those patients should be isolated from the patients who are having less cough symptoms, or they are on oxygen and all, but having less respiratory symptoms. So those areas should be the patients are also need to be separated from or if it is necessary. For example, in previous lecture, Dr. Dute sir has told that it is necessary to give it is necessary for some patients to give physiotherapy. So for giving physiotherapy, a different isolated room should be there. Why? Because while giving physiotherapy, there are more amount of aerosol production. So it can increase the viral load for other patients also. So a dedicated room should be there for giving the physiotherapy to those patients. Room must be, and these rooms which are there, they must be decontaminated in 20 minutes. So it is necessary to decontaminate these rooms where high amount of aerosol production is there with 1% sodium hypochlorite disinfectant after procedure is performed in the patient's room. So if the patient is isolated if the patient is isolated in a single room, that has to be cleaned in every 20 minutes with 1% sodium hypochlorite. This is ideal condition or ideal situation I'm telling you. It should be disinfected in every 20 minutes with 1% sodium hypochlorite. And if those procedure, for example, intubation has been done, or suction has been done, or the physiotherapy has been given to the patient, so in that case, that room should be isolated after the procedure. That room should be isolated with 1% sodium hypochlorite. Then about different types of equipments. If reusable equipments are used, decontaminate them with soap and water with high level of disinfection before removing the room. So those equipments which can be washable, they has to be washed with proper soap and water. So soap and water is the best, a kind of you can say that soap and water is the best disinfectant which we can. Those equipments which are washable with water, just go for washing. Then next, use dedicated equipment in isolation room. That means those equipment should not come after, should not come for any reason. These equipment should not come out of that isolation room. Avoid storing extraneous equipments in the patient's room. So unnecessary equipment should not be there in the patient's room. Dispose of single-use equipment as per clinical waste policy inside room with 1% sodium hypochlorite. So I'll tell you in details about which material has to be disinfected in which types of beans, and before discarding them, which items should be disinfected them, it is necessary to disinfect with 1% sodium hypochlorite. I will tell you in that part. Closed suction system should be there. Encourage use of disposable cutlery in patient's room to minimize decontaminating many items. So use and throw items should be used for those patients. Paper dishes and all. So infection prevention control in critical care, use rapid sequence intubation techniques to minimize the aerosol generation. Aggressively control and suppress the patient's cough as possible. If possible, first try to, I'm talking as a microbiologist, I'm talking from the infection prevention, my view is to prevent the infection for other staff, healthcare workers, to minimize the viral load. Therefore, I will recommend that if the patient is having severe cough, then the first important thing, or the important thing is that the aggressive therapy should be given to prevent or to reduce the cough of the patient. use high efficacy particulate area or HEPA filters on ventilators, or at minimum inline HEPA, HME or HEPA filters on the endotracheal tube. So not only it is important in the room, that is we should have HEPA filters and all, but also the endotracheal tubes which are there for the which are used for those patients who are on ventilator, they should have HEPA filters. Monitor the guidelines which are given by government and the latest literature to determine the potential efficacy of the antiviral and other techniques. So to prevent the airborne infection, or at the same time to provide a ventilation for the patient, which strategy has to be applied? Because this is a big question mark, that we are saying that patient has to be isolated, and in the same time I'm saying that there should be minimum aerosol minimum aerosol should be there in the generation in the room. So which strategies we can follow from these different types of fans and all? So whether we should use fans or not in isolation wards, so yes, we can use different types of fans, but it will depend upon the condition of the room or the structure of the room. Choose the fan based upon what you want the fan to do. Cool ambient temperature through dissipated radiant heat. As we know, the second surge was in the month of April and May. At that time, the temperature was very high, and the patient is already having low amount of saturation, and also the patient was going in distress because of the high amount of heat and the low amount of oxygen. So in that case, we should provide the ambulant facility for transfer of air and all. Therefore, fan should be there. Provide directionality in order to improve the ventilation. That is to if we want intake, then suck air out of the room, and for outtake, blow air in the room. So this is the ideal situation, or this is the ideal condition where this is the healthcare worker who is providing the treatment to COVID-19 patient. The patient is wearing mask. Here, the fan is providing air, or it is blowing the air from back of the healthcare workers, and it is getting exhausted from this exhaust area. So this is the ideal condition, or this is the ideal situation in which we can provide the ambient air to the patient, and it will also help in air changes. So I'm going to talk about the air changes per hour. So this is the ideal conditions. Direction of fan should deflect the air away from the healthcare worker. That is, airflow should go from healthcare worker to the patient and not in the opposite direction. So this should be the airflow from the fan to the healthcare workers to the patient and then out. The use of either fan pictured would work. Can I use fans to direct airflow? So yes, that is the best use of fans. The best placement for fan is near the window to help air exhaust out of the room. Make sure that fans are not exhausting air into busy corridor. So we have to take care that while exhausting the air which is there in that room, they should not exhaust the air into the area where that means the air should not getting exhausted to the busy corridor, the patient who are not suffering from COVID-19. So we have to take care before doing all these things. Air changes per hour. Actually, it's a scientific thing. I just want to focus upon this thing, that for isolation facility, normal atmospheric pressure, that is not for normal room ventilation, 6 air changes per hours is necessary. So what basically air change per hour is that the air which is there in the room, it should, in basic term or in simple term, air which is there in the room, there should be frequent. The concept is that per hour there should be complete the air which is there in the room, it should get completely out of the room and fresh air should come inside. So this is the air change. And And for healthcare setting, government or CDC has given a particular guidelines for minimum air change per hour required for various healthcare care facilities. So if it is a registration area, then minimum 6 air change per hour is necessary. So in registration area, in an hour, there should be 6 air changes in an hour. That means the air which is coming there, which is coming in that registration area should go out. So the fresh air for per hourly, there should be 6 times, at minimum 6 times the fresh air should come in and go out per hour. Minimum 6 air changes should be there. So for registration area, it is recommended that 6 air changes per hour is necessary. If it is outpatient department and the waiting area, then also same, more than 6 air changes per hour is recommended. Then for inpatient department also more than 6 patients. I'm talking about the wards where we have isolated, where well ventilation is present and the patient have been isolated with 1 meter distance. And for the high risk setting and their waiting areas or the centers, more than 12 air changes per hour is recommended. So this is a scientific term. I'm not going into details of that, how to calculate the ventilation flow rate and all. Why I'm telling you that how the opening windows and doors can increase the number of air changes per hour in a ward. So why it is necessary? Why I'm telling you? I maybe you must be thinking that I'm giving the contradictory statements. First I'm telling you that there should be isolated room, the door should be closed and all. At the same time I'm telling you that there should be proper the doors and windows should be open for proper air changes. But what happens if we give, or if possible, if we can give the dedicated area for the COVID-19 patient, it is very good for those patients also. So if you are giving those if we are dedicating separate wards, then for those wards the windows as well as doors should be open. So we have to give a separate area or a dedicated area for those patients. So I'm directly going to this chart. So open window, if 100% open window and open door, there are minimum 37 changes per hour of the air. That means the 37 times the air changes in an hour if both the door as well as window is fully open. Okay, and that too naturally. We don't have to use any kind of fan or any kind of ventilator or exhaust area. Even if we keep the door and the windows open, then 37 times the air will change per hour. So it is important to open the window as well as doors. Then if open is the window is half open, that is 50% window is open with open door, then there are 28 changes per hour. That you can see the difference. If the windows are half closed and if the door is open, then 28 times the air can change in an hour. But if open window and door closed, then only can you see the difference. Only 4.2 changes are there in air per hour. So it is very important while giving the dedicated area to those patients, both the windows and the air should be open so as to provide maximum air changes per hour. So how we can do environmental decontamination? Cleaning and decontamination should only be performed by staff wearing appropriate PPE. So not only the healthcare workers which are treating or which are giving the actual nursing staff and all should wear PPE, but the class 4 workers should also wear PPE while cleaning and decontaminating the area. After cleaning with neutral detergent, a chlorine-based disinfectant should be used in the form of solution at a minimum strength of 1000 ppm available chlorine. Main patient isolation room, aerosol generating procedure room, or other potential contamination procedure room should be clean at thrice a day. So minimum, what I told you, it is ideal that we should clean it with 1% hypochlorite after every 20 minutes, but at least minimum we have to clean it at thrice a day with 1% sodium hypochlorite. Frequently clean commonly used hand-touched surface area and anteroom or lobby areas at least thrice per day with 1% sodium hypochlorite. So about linen, which is there used by the patients, label linen inside the patient isolation room in accordance as infectious linen. So we have to properly label the linen which is used by the patient and properly label it as a infectious and put infectious linen and put a hazard sign over that linen so that it will not get mixed with the other linen. Disinfect infectious linen with 1% sodium hypochlorite by soaking for 20 minutes. So before discarding that linen also, we have to soak it into 1% sodium hypochlorite for minimum of 20 minutes, and then we can discard the linen. Linen must be carried in bags through the ward or the other clinical area. So what are the guidelines for healthcare workers who have contact with a positive case? If we are serving in a COVID-19 dedicated ward, then what precautions? So what are the guidelines which are available by Ministry of Healthcare Workers and Ministry of Family and Healthcare Worker government? Symptomatic healthcare workers providing care to the confirmed cases should be tested once between day 5 and day 14 coming in contact with the patient. All symptomatic healthcare workers should be tested as per revised strategy of COVID-19 testing in India, version 3 dated 20th March. So ideally, you are serving if you are serving then for each 14 days, it is recommended that you must be knowing that after 14 days a gap of 14 days is given. So after 14 days you can get checked with RT-PCR for COVID-19. The strategy changes with evidence of community transmission. Additional guidance is available on ICMR and the government website. 3 main ways to protect the healthcare workers from getting COVID-19 is limit the infection entering into your facility. So if your facility is not been dedicated for the health, for giving the tertiary care for these patients, then first thing is to limit. So how to limit? First is to cancel the elective procedures which are there. So ideally, the elective procedures which can be postponed, they should be cancelled. Use telemedicine when possible. Limit points of entry and manage visitors. Screen patient for respiratory symptoms. Encourage patient respiratory hygiene using alternatives to face mask. For example, tissues to cover the cough. That means all the necessary precautions. First is to prevent the patients which are there. First is to prevent the mixing of the patient of having respiratory symptom and not having respiratory symptoms. For those who are having respiratory symptoms, possibly give the telemedicine therapy. For those who are having more severe symptoms, then call them and again do triage. Those which are coming to the hospital, again do triage. Who are having less symptoms, who are having more symptoms, and those who will require the intensive facility and all. Then based upon triage, you can isolate the patient and give further treatment. Isolate symptomatic patients as soon as possible. Set up separate well-ventilated triage area. Place patient with suspected or confirmed COVID-19 patient in private rooms with door closed and private bathrooms as possible. If available, prioritize airborne infection isolation room for patients undergoing aerosol generating procedure. That means, again, what I have told you previously also, the procedures in which there are high suspicion of aerosol production, try to isolate them in separate rooms. Protect the healthcare personnel, emphasize hand hygiene at each and every point, install barriers to limit the contact with the patient, cohort COVID-19 patients. Cohort means to cluster the patient at one place. Then limit the number of staffs providing the care. Cohort staff working in isolation room. So the healthcare worker who are serving those patients, they should be also isolated from the other healthcare workers or other family members. Then prioritize respirators and airborne infection isolation room for aerosol generating procedure and implement PPE optimization strategy to extend the supply. That's what I have told you, that the PPE should be used carefully. That means we have to, while using the PPE, we should optimize the use of PPE so that we can give those healthcare workers in which it is giving PPE is necessary. How to ensure the surgeon or the staff they are safe when doing surgery. So if it is necessary to do surgery on COVID-19 patient, what precaution has to be followed? First thing is elective surgeries should be postponed. Then standard infection control practices should be followed in the OTs. Take precaution when performing aerosol generating procedure. Then operating room should be allocated and signs posted on the doors to minimize the staff exposure. If no general anesthesia, then patients should continue to wear the surgical mask while doing the surgery. If general anesthesia is used, then place a HEPA filter between the Y-piece of the breathing circuit and patient mask, endotracheal tube or laryngeal mask airway so as to prevent the aerosol production. If available, use a closed suction system during airway suctioning. For planned surgeries, postpone unless essential. Prepare OT. Educate surgeons, develop preparedness plan for providing essential operating system for pandemic, decrease exposure of healthcare staff, particularly surgeons, develop dedicated COVID-19 OT. If it is necessary to do to do operations for COVID-19 patient, for example, mucormycosis, we all know that there are many patients of mucormycosis which needs to be operated urgently. For those patients, a separate OT should be dedicated. Prepare for repurposing OT to support the critical care patients. So do we need to isolate all the patients in airborne infection isolation room? No. Airborne infection isolation room should be reserved for the patients undergoing aerosol generating procedure or for the patients having active cough. Patients with known or suspected COVID-19 should be cared for a single person room with the door closed or cohorted in well-ventilated wards with a bed at least 1 meter apart. Now, the last part, biomedical waste management. There are different steps for biomedical waste management. First is waste segregation. That means at the point of generation, the waste should be separated into the different color-coded container. Pre-treatment with laboratory liquid waste at some point. Transport of waste from generation site to central storage area of the hospital for biomedical waste. Then transport of waste from central storage area to common biomedical waste treatment facility. That is where all the hospital waste comes together. So it is a central or it is a common biomedical waste treatment facility. Then treatment and disposal of the waste should be within 48 hours. So we should not keep that waste into the hospital more than 48 hours. It should be discarded within 48 hours. According to Biomedical Rules 2016, segregation of waste generated during screening, treatment, and immunization of COVID-19 patient and healthcare staff who are working in those hospitals should be that is, the segregation should be done into 4 different color containers. So I'm quickly going through all these containers. So first we'll start with yellow. So what has to be discarded in yellow bins? Soiled waste like items contaminated with blood, excluding blood bags and body fluids or cotton swabs. Pre-treatment is not necessary. Incineration has to be done. Final disposal. Chemicals which are used in the labs, liquid waste generated in the labs used, or disinfectants to be discarded. Then infected secretions, aspirated body fluids, fluid washings, and other housekeeping and disinfecting activities in yellow bag. Pre-treatment separate collection system leading to effluent treatment plan for pre-treatment and neutralization. So the body fluids which are collected from the infected patients or the soiled fluid which is there need to be for those a separate effluent system is necessary. Final disposal, the pre-treated liquid waste shall conform to the discharge norms, and then it is led to the general drain. Again in yellow, personal protective material like face mask, gown, cap, etc., which is made with the fiber material, or others, except for those made up of disposable plastic. So other than plastic material, the which you are using, that is face mask or gown and all, they should be discarded in yellow bin, and the final treatment will be incineration. Then discarded linen beddings contaminated with blood or body fluids of this COVID-19 patient has to be discarded in yellow bag. Pre-treatment is not necessary. They has to be discarded by non-chlorinated chemical disinfection followed by incineration. Then microbiology and laboratory waste like culture, stock specimen, vaccines, dishes and devices used for the cultures and blood bags has to be discarded with pre-treatment with the non-chlorinated chemicals or autoclave or microwave or hydroclave. That means before putting them in the yellow bag, we have to pre-treat them with microwave, autoclave or hydroclave or some non-chlorinated chemicals, and then finally pre-treated and followed by incineration. Now in red bag, gloves, even if contaminated with blood and body fluids. So gloves should be put in the red bag. These are the recommendations given by Government of India. There are different recommendations which are followed by different healthcare system, but I am giving you the recommendations which are there by the government. Autoclaved shredding. So gloves, pre-treatment is not required. Autoclaved shredding should be given followed by recycling. Then IV tubings, bottles, sets, catheters, urine bags, and vacuotiners in the red bag. Pre-treatment is not necessary. There has to be autoclaved and shredding followed by recycling. Why these gloves? The rubber gloves, basically, I'm telling you, the rubber gloves and the bottles or the plastic gloves or the rubber gloves, they can be recycled. Therefore, they has to be put in the red bag. So the material which can be recycled, ideally it should be put in the red bag. Okay. Then it is autoclaved and shredded, and it can be used further for recycling purpose. Broken or intact glassware, medicine vials, ampoules, except for those contaminated with cytotoxic waste, can be put in blue puncture-proof container. Pre-treatment is not required, and the disinfection and then recycling. The metallic sharp waste like needles, scalpel, blades, syringes with fixed needles, they has to be discarded in white bag, puncture-proof, leak-proof, tamper-proof container. Pre-treatment not necessary. Autoclaving and shredding followed by encapsulation or disposal of in iron foundries. So I'm giving you simple clue if it is difficult for us to remember, which waste to be discarded in which bin. So it is a simple thing you can remember. What will go in yellow is the one which can be incinerated, that we can directly put in a fire. So the material or the waste material which we can directly burn off, we can put it in a yellow bag. So we have, before putting the waste into any bag, we have to ask ourselves few questions. First question is it an infectious soil waste that can be incinerated? Incinerator you must have heard also. What is there in incinerator? Incinerator basically, it's a big plant where high temperature is there and all, which actually burns all the waste. So if the waste can be burned out easily or not having any hazard to the environment, then we can put it in a yellow bag. First thing. Then secondly, is it a disposable recyclable plastic? If it can be recyclable, if it is a plastic and which can be recyclable, then you can put it in the red bag. Therefore, I have told you rubber gloves, even if contaminated with the blood. Then second thing is tubings, where types of tubings, then where various types of catheters and all, they has to be put in a red bag. Is it a reusable glassware? If it is a glassware, obviously we have to put it in a blue container, puncture-proof container. It's a metallic sharp that can cause injury. If it is a metallic sharp, then we have to put it in a white container. Okay, so it is not the bag; it will be a container which will not cause harm to the other class 4 workers. So we have to put that sharp into the puncture proof water transparent or white container. And finally, the material which is there or the waste which is present in the yellow bag will go to the incinerator for fire. Okay, so finally it will be burned out. The one which is going in the red bag, it will be dangerous or plastic which can be shredded. First it is autoclaved, then it can be shredded, and then it can be recycled. The one which is the waste which is there in a blue bag, it can be also reused as a glass container or vials. And the one which we are putting in a white, that is sharps, various sharps, finally they will go to the cement or encapsulation, and finally they will be discarded by putting cement blocks, by mixing them in a cement blocks, and finally they will be discarded. So with this, I'm ending my session. Thank you so much for cooperation.
Thank you so much, ma'am. Next, we have Dr. B.D. Pavasar from the Department of Otorhinolaryngology talking about mucormycosis.
Good afternoon. Today, I am going to discuss about the very important silent feature of the mucormycosis in clinical as well as public health point of view. So, why this mucormycosis will to be discussed? Oh, you know, the last few months back, after the second wave of the COVID, the mucormycosis has created a lot of problems in the community and put a huge burden on the health infrastructure. Now, the objective of this regarding discussion mucormycosis is what is introduction of the mucormycosis. Then know about the risk, what are the risk factors for that. Then familiarize with the signs, symptoms as well as the precaution measures. Then learn about the investigation and diagnostic tests for the mucormycosis. Then describe the treatment plan and what are the post-treatment reconstructive surgeries possible after the mucormycosis surgery. The mucormycosis is not new disease to everybody, but occurrence of this disease was very rare or minimum. You might be seeing few cases during your curriculum. Now the mucormycosis is first reported by the Urchin Messer in 1855. Previously, it was also known as zygomycosis. Now it is due to the recurrence or reoccurrence. Now it is grouped in the new emerging diseases. Now it is one of the opposite fungal infection aggressively involves all the vital structures of the body. Okay, what is the causing agent? Now it is caused by the mucormycosis belonging to the order Mucorales. Commonest causative agents are the Rhizopus, Oryza, Rhizomucor, and other group. Now now regarding about the just now the incidence of that mucormycosis was 300 times was more as a normal case during the post-COVID regions in the COVID patients, and morbidity mortality was there about 31 to 50%. Usually the fatality of this disease. Now the reservoir. How you epidemiology tried where there is a host agent and atmosphere. The reservoir is funguses are commonly found in soil, air, waste areas, rotten woods, leaves, and in the contaminated surgical dressing of the mucormycosis patients and non-sterile adhesive tapes. These are the common sites for the mucormycosis. Now as such disease, what are the types of disease? Now the mucormycosis is present in the host in the 5 categories. First is the rhinocerebral, which is very common. Second is pulmonary. Third is gastrointestinal. Fourth is cutaneous. Fifth is disseminated mucormycosis. What are the routes of infection? The commonest route of infection are the inhalation, skin, oral, and sometimes this can be spread by direct access to the susceptible host by use of contaminated appliances. Means, for example, if patient is mucormycosis patient and his subutensils or some surgical instruments are used for that. If they are not autoclaved properly and they are used by mistake, they are used with the other susceptible host. This host can get such type of infection. Now the pathogenesis of the mucormycosis is very complex phenomena. Now pathogenesis of the mucormycosis related to the following factors. First is the host defense. Now the host lack of phagocytics or impaired function of the phagocytes are having high risk of the mucormycosis, particularly those patients are neutropenic. Now the T lymphocytes have the inhibitory action for the proliferation of the fungus. When there is a problem with the T lymphocytes, again fungus infection may spread. Then mono and polynucleoside phagocytes of the normal host kill the fungus by generation of the various oxidative metabolites and certain peptides. Again, in the body, due to the low pH and hyperglycemia leads the hypofunction of this phagocytes, and that leads to the impaired function of phagocytation, leads to the host is susceptible for the infection of the mucormycosis, as killing mechanism is held. Now the second is about the mucormycosis. Firstly, it has a endothelial interaction, means it affects first the blood vessel walls, and that leads to the necrosis of the certain tissues. Now, there are certain comorbid conditions which are responsible for the mucormycosis or generation of the mucormycosis. As usual, normal patient, those patients who do not have any comorbidities or underlying disease may not suffer from the mucormycosis, but certain patients who are like having the certain comorbidities like the diabetes or diabetes, what happens in such condition due to ketosis or on the dialysis, there is a increase in the iron level. Now this mucormycosis or fungus has good affinity for this iron. Even along with the iron, some people say that these are having also affinity to the zinc. That's why since the second wave, tremendous use of the zinc was carried out. So that may be one of the possible reason for the mucormycosis. Then what happens when any host is infected? That affects firstly the vascular structure, and that leads to the necrosis of a tissue. And after the necrosis of tissue, the area becomes black, and afterwards, black scab is formed, and that scab prevents the liberation of the leukocyte, which has anti-inflammatory activity, as well as the anti-fungal agent cannot reach to the lesion site. That's why you have to do the antifungal treatment for the longer period. Okay. Along with this black fungus, this number of white, yellow, green fungus almost there belongs to the same family. Now, what are the risk factors for the mucormycosis? Now, what are the risk factors? Usually, occurrence either post-COVID treatment patient or during the COVID treatment, and maybe 1 to 3 months after the COVID treatment. Now, most of in about the 70%, there is a history of COVID infection, but in 25 patients, there is no history of the COVID infection, but have certain comorbidity conditions. Now, what are the major risk factors. These are the combination uncontrolled diabetes mellitus, immunosuppression by steroids, treatment with immunoglobulin mediators, then prolonged ICU stay along with the O2 therapy, long-lasting oxygen therapy, especially by nasal prongs, then comorbid condition, this form, the organ transplant patients, then chemotherapy balance treatment of the patients on the chemotherapy, malignant patient of the chemotherapy, then some patients on the fluconazole therapy for the other fungal infection like aspergillosis, then long-term rise to feeding, humidifier bottle contamination, prolonged use of the higher antibiotics, chronic kidney disease, chronic liver disease, then neutropenic patients, and patients of the hematologic patients, then skin injury and burns, premature and low birth weight babies. These are the major risk factors responsible for the mucormycosis. Now, let us see what are the sign symptoms. My sign symptoms depends upon the type of mucormycosis, but commonest are the fever, headache, cough, pain, redness around the eyes, nose, shortness of breath, bloody vomitus, altered mental status, blackish discoloration, discharge, blackish discharge over the bridge of the nose and palate, then toothache, mobility of the multiple tooth or discharge from the affected mucosa, palate, gums, and vestibules, then nasal block, then nasal blackish or bloody discharge from the nasal cavities and with foul smell. Then ophthalmic symptoms like ophthalmoplegia, blurred vision. Some patient may have abdominal pain with GIT bleeding, and those patients have injury over the skin or the cutaneous types of mucormycosis. They have blisters over the skin. Now, what are the precautionary measures? They are very important. Now, first is a personal hygiene or hand hygiene. Means when you are handling any patient, either COVID patient or mucormycosis patient, your personal hygiene should be maintained, as every patient should be handled as he is positive for some infective conditions. Then use of mask. Now, the continuous use of mask that leads to humidification, and that humidification again is responsible for the growth of the fungus. So the continuous, as far as it means, one thing is the mask should be changed frequently, or that should be routinely clean with hypochlorite solution and then use, or repeated disposal that should be used, dispose frequently. Then judicial use of the antibiotics, antifungal, steroids, drugs. Most important is the control of the hyperglycemia, means monitoring of the blood glucose level of the COVID patient during the treatment period or during after the discharge. Then use of the clean sterile water for the humidification during the oxygen therapy, O2 therapy, nasal cannula should be clean. That is very important. What happens after the first wave? The oxygen consumption was not much more. After the second COVID wave, the number of patients were increased, severity was increased. So oxygen consumption was used, and due to the shortage of the generation of the oxygen or supply oxygens, at an emergency basis, the number of oxygen generation plants were erected, and at that time, the certain things may not be taken in the account. For example, the clean water, then pipeline, other or mask, then humidification, water may be, or the oxygen bottles, whatever may be. Then about that, cleanliness about this may not be taken, and that may be one of the responsible for the occurrence of the mucormycosis. I will just give you examples. In certain hospitals, particularly from the ICU, the swabs were taken from the oxygen masks, tubings, and oxygen bottles, and they came positive for this mucormycosis fungus. Means one thing, there may be humidification, one is responsible for the growth of the second thing, cleaning protocol may not be used. Second thing, there may be chances of reuse of these things due to the shortage of the less supply of these things. Then adequate maintenance of the hydration. Then infusion of normal saline, prior infusion of the amphotericin will see the further. Monitor patient clinically and radioimaging response, detection of the discharge progression means the follow up the patient is very important. Then prevent dirt and soil exposure. All walls of the roof should be dust and mold proof. You have seen during the rainy season or due to the humidification, there is a huge growth of the fungus. You take the examples of your fridge. If you keep the fridge closed for the few days, after the opening the fridge, you see the profundous growth of the fungus. That may be not be hazardous water may be. And like this, due to this humidification or the wet soil or wet area, this fungus very well grows, particularly in the rainy season. Then no water logging in the area or around the COVID ward, or there should be good ventilation. AC ventilator must be clean and filter should be frequently changed. That is very important. And lastly, no construction work around the COVID ward. What happens? Whenever this COVID ward is started, so there is a deficient of the COVID ward. When COVID ward simply along with this for the certain construction or repair, what things are going on? These things should be avoided nearby your COVID ward. And lastly, the public health laboratory should be asked to take the swabs of the humidifier, mask, tubings, and common touch area for the culture of the mucormycosis. That I already told. Now what apart from the just I have done the precaution measure, what things to be does and not to be done. I will not discuss that. Already I have discussed that. Now after the suspicion, the mucormycosis patient, what are the diagnostic tools or what initially should be carried out? Now first is a through clinical examination, what types of that mucormycosis. Then certain lab investigation like the blood investigation or routine investigation, electrolyte, the CBC, ESR like this. Then the radiology studies, that is CT paranasal sinuses with contrast or MRI with contrast. Then nasal endoscopy, suspected cases. Then biopsy should be taken from the either biopsy may be tissue biopsy, bone biopsy, aspiration biopsy, and that tissue material or suspected infective material should be sent to the for the KY staining and microscopic examination. Now this again this material should be subject for the culture and sensitivity, but for the different, the culture and sensitivity of the fungus takes much time, near about 3 to 4 days. That you should not wait for till the culture sensitivity report comes. You should start immediate treatment. Now, recently there is a metric acid laser deabsorption ionization time of flight is one of the method. That is one of the spectroscopic method. Here you can detect the various organisms like bacteria, fungus very well. Now about the biopsy purpose. Now from the lesion of the oral cavity, biopsy from the deeper portion of the extracted socket or exposed bone should be taken, or nasal cavity from the nasal endoscopy, and that crust which is seen in the nasal cavity, that is to be taken and sent to for the exam, the laboratory investigation. Then direct microscopic of the bronchoalveolar lavage means if you are suspecting the pulmonary mucormycosis by doing the bronchoscopy, some fluid collected from the lungs that is sent for the examination. Now, how the sample is to be sent. Now, for the alkaline study, the QA study, that biopsy material should be preserved in the saline material. Then for the culture material should be preserved in the saline material. For histopathology material, that should be preserved in the formaldehyde. Then further section material tips for the preserved in the saline, and swabs or fluids again that is to be preserved in the saline. Now after the diagnosis or suspected case or diagnosis, immediately treatment should be started. A delay should not be there. For the successful treatment of mucormycosis requires 4 steps. First is early diagnosis. Then reversal of the underlying predisposing risk factors, means treatment of the underlying disease like diabetes or kidney treatment of the kidney failure or whatever may be. Then third is a surgical treatment, that is surgical debridement. And lastly, prompt antifungal treatment. Now, management of the mucormycosis patient needs a group of specialists. Team should include infectious disease specialist, microbiologist, histopathologist, anesthetist, intensivist, neurologist, ENT surgeon, ophthalmologist, dentist, radiologist. They should be available at any cost. Now let us see what is the medical treatment. Now the first medical treatment is a control of the diabetes and its complication like ketoacidosis. Then judicial use of steroids. Then antifungal drug therapy. Then sepsis control, infection of the other organisms like bacteria or water may be. Then respiratory care. Those patients having the pulmonary type of mucormycosis may have respiratory stress. Take care for the respiratory care should be taken. Then physiotherapy, chest physiotherapy, very important, like food. Then care of the nutrition. Apart from the medical treatments, there is a major role of the surgeon. There either may be dental surgeon, there may be ENT surgeon, pelvic surgeon, neurosurgeon, whatever. Depends on the type of lesion. Now the basic principle is debridement of the infected tissue, bone and tooth. all the deported tissue or suspect tissue should be removed or that should be deprived. If you keep some tissue, that may happen, there is chances of recurrence. Killing and debridement of the all sinuses, removal of the necrotic tissue, and sometimes if lesion is major, then you made the maxillotomy or other like orbital extension like this. That depends. If extension is even intracranial care, then there is a role of a neurosurgeon. Then you may need to for the intervention. But if infection spread to the intracranial, the outcome is very poor. Now, what is the medical drug use for the treatment of the mucormycosis? Now, before the starting of the antifungal drug, that patient should investigate for the renal function test, liver function test. If liver function or kidney functions are abnormal, then again type of drug is to be changed. Now, first drug of choice is amphotericin B. And if patient is having altered liver or kidney function, then use the liposomal or lipid formulation amphotericin. Now, those are the amphotericin is the registration form is 1 to 1.5 milligram per kg, and liposomal amphotericin is 5 to 10 milligram per kg for 40 to 20 days. Apart from this, you can do the oral oral drug can be given as a adjuvant therapy. 300 milligram, 100 milligram, 40 for 45 days. Now, this is the amputation B admission protocol. This I will discuss. Now, prior starting of the amputation B, as amputation B is very toxic drug or it is very nephrotoxic drug, then prior to there is hydration is done with the help of the normal saline, and along with this, the calemic factor should be taken in the account to reduce the renal toxicity. And how the drug is prepared, hydration is made 1 gram with 10 ml. Always use 5% of it, 10% of dose. It is very important. Avoid normal saline. Then 500 milligram normal saline should be given pre-infusion. If fluid is overloaded, then pre-hydration is preferred. If they use the normal salt instead of the normal side, that is isotonic solution. And very important, if where you are giving the amputation by infusion, the sunlight should be avoided. Sunlight is focused on this infusion, then there may be changes in the fluid or the drug. Now, very important. Now, your machine in the during after the COVID patients or after there are number of patients are having some psychological changes. Same thing is applicable here. That disease is very fatal as patients are the mucormycosis spreads very fast. So psychological assistance should be given to the patient along with rehabilitation is very important. And the treatment of the mucormycosis is very costly. So financial support should be given to the patient by different methods. Maharashtra government has specially made the provision under MPJY scheme. Under this scheme, patient get the treatment in the hospital who are arrested or impaneled under the MP Mahatma Phule Jyotiba Phule Jeevandai Arogya Yojana. Now after the surgical procedure, there will be sometimes this surgery may be extensive. There will be for disfigured face. Certain reconstructive surgery may be needed, either that in the form of plastic surgery or various implants, like the zygomatic implants, obturators, pre-surgical obturators, intermediate obturator, definitive obturator, then artificial orbit, nose, ear, maxilla, and subsequently the reconstruction of the plastic surgery. Now, in the mucormycosis treatment, human research management is very important. That treatment of the mucormycosis needs multiple specialty. So all types of specialty should be made available by the health authority or the authority of the health institute who is providing the mucormycosis treatment, either in the form of the block basis or event basis, whatever may be. Again, logistic management, it is very important. Then sufficient amount of quality of the medicine, surgically disposable materials stock should be available in the hospital. Mucormycosis treatment is going on. Then supportive management. As far as possible, all types of supportive management like the radiological services, then laboratory services, or other different types of services should be made available under a single roof. As far as possible, should be available. There should be the transportation and other things. Now, the public health point of view, a referral plan is very important. Now, when in the periphery, when their patient is suspected by the medical officer or health worker, that patient should be referred directly to the health center or medical center where this facility is available. Either what happens if patient is diagnosed in PSC, that is reported to the rural hospital subdivision. Again, this is from subdivision hospital, that is to the civil hospital. This should not happen. Once patient is subjected, that should be directed to the referred to the directly to the health center or medical center where this facility treatment facility is available. And that may be either in the form of the district hospital or medical colleges or identified the private hospitals which are implanted under the MPGY. The importance of this referral plan is that there should not be loss of time during the referral, and earliest medical treatment will start. If you delay medical treatment, again the outcome will be not proper. That's why as early as possible, the medical line of treatment in such patients should be started immediately. Now, IC activity. Now, this is very important. The surveillance in that area, just like other diseases, means what happens. Our health machinery or health workers, those who are working at the sub-center or PSC, whatever it may be, they are having the appropriate available data of their patients of that area. Like for example, I will take the examples of the maternal child tracking system. Means that health worker is having knowledge of the how many cases are the pregnant women are in that area, how many childs are there, what is expected, like this. Means this health worker should know the how many COVID, post-COVID patients are our area, and follow-up of this patient should be done by different means, by tracking up in the these various camps, the immunization camps or physical diagnostic like this. This patient should be observed or follow should be taken. And if patient is suspected, this immediately patient should be referred. That is the my motto for this surveillance activity. Then poster banners at a prominent places about the health activity, health education about this mucormycosis should be given to the public. Then camps for the post-COVID cases, just like now the fungal disease awareness week is in the September. Is 224 means last week that was celebrated as a the fungal disease awareness week. That may be not the mucormycosis alone for the mucormycosis, that may further related to the other types of fungus. Now these are the different types of photographs. Thank you.
Now, as we have come to the end of our session for this continued educational program, I would request Dr. Gunjal Madam to give the vote of thanks.
A very humble good afternoon to all those extremely learned, the dignified, and the so very beautiful audience out there. Well, although I'm pretty accustomed to be across the podium to address a class to my children, today I feel very special because I'm best off for having been given the responsibility to offer gratitude to all those who have contributed towards the CME. So, on behalf of the Department of Microbiology, it's my proud privilege to extend a vote of thanks to all the respected dignitaries, participants, and the volunteers for the CME. Seeking the blessings of the most revered Dr. Vittalrao Vikhe Patil, the emblem of foresight and revolution. There are no words which convey our respect and gratitude towards him. I express my gratitude towards Honorable Namdar Shri Radhakrishna Vikhe Patil Sahib, former Minister, the State of Maharashtra, and Honorable Dr. Smijay Vikhe Patil Sir, the Chief Executive Officer, Dr. Vittalrao Vikhe Patil Foundation, Member of Parliament, the Ahmednagar Lok Sabha constituency, whose never-ending support has brought us all together here today. At the outset, I place on record my sincere gratitude to Honorable Lieutenant General, retired Dr. B. Sadananda Sir, Secretary General, Dr. Vittalrao Vikhe Patil Foundation for his encouragement. It is my privilege to be grateful to Honorable Dr. Abhijit Tute Sir, Deputy Director, Dr. Vittalrao Vikhe Patil Foundation's Medical College and Hospital, for his steady support not only for the CME but also throughout. I now place on record my profuse thanks to respected Dr. Sunil Maske Sir, Dean, Dr. Vittalrao Vikhe Patil Foundation's Medical College and Hospital, for his foresight gave us an impetus to carry out this CME. I am also thankful to respected Dr. Satish More Sir, Medical Superintendent, Dr. Vittalrao Vikhe Patil Foundation's Medical College and Hospital for his support. It's a matter of immense pride for me to convey my gratitude to all the learned speakers who made the CME an academic feast. A huge thank you to all the delegates without whom the CME would be next to impossible, and also for making that patient and interactive audience. I'm thankful to the organizing secretary and his team for their exhaustive efforts, but they've been on their toes all throughout. I'm also thankful to the volunteers, the administrative department, the civil department, the maintenance, and the electric department for their valuable help. Once again, I thank everybody who, despite being very busy, have joined with us. Before leaving, I would like to express something heartfelt. You know, we always aspire to apply our knowledge. We always try to implement what we learn. But the COVID pandemic shall be a situation for which we would always pray to God that there never comes a moment that requires to apply what is learned. The aura of your presence and the delegation shall linger, and let's be hopeful that the pandemic comes to an end very soon. Thank you.
Good afternoon. We are coming to the session as a part of the CME. As organizing secretary, I would like to thank all the speakers here. They have given their valuable time. The Department of Microbiology has taken so much of efforts. There are more than 300 these registrations. This is really a big efforts, and really I'm thankful to them, all of them. Second thing, I'm thankful to the management who has given the extensive support. All the time they are supporting. Yesterday also I talked the same thing in introduction. They are supportive for all academic activities, and also all the whatever the mistakes we do, they always make us to learn from those mistakes, and they tell this is a mistake and this is a good thing that you have done. So again, I'm thankful to all non-teaching staff and the maintenance department and all the whole institute, and most of the Dr. Sujata Vikhe Patil, our member of parliament, who is also inspiring for us all academic activities, Dr. Abhijit Tute sir, Dr. P. Sadananda sir, for giving me the, I have completed 7 years in this institute, but they are giving the extensive support for each and everything what I have said, they have done it. Right? So thanks for their support, because I have been associated with Vikhe Patil since last 70 years, 70. So civic UK Patil, we started in 1949. This is my third generation working in UK Patil. And now it's just really how to thank them. We are also doing the same thing what they wanted since last 70 years, 70. And also they also got faith on us. So thank you very much for this, your kind support. And I have seen many of the members who are asking for the questions on the WhatsApp. Some people, they have demanded the PPTs from the outside, and they appreciated the presentations. So thank you very much for this. Looking forward. Thank you.
Thank you, sir.